Ends up doing your cucumber salad. All right, very good, very good. Your mothers would be proud. Those of you who didn't, you can't come back next year. All right, so before we start the video, putting together something like this is a team effort. It's not just one person, but there is somebody very special. Where is she? Where's Kathy go? I told her to stay put. We're gonna go around and around. You know Kathy, if you ask her to stay put, she'll move. Okay, there she is. Okay. So I was going to say some nice things about you. So Kathy Hurd has been a phenomenal friend, very, very graceful person. She is so professional. She has such a great vision. And putting this all together would not have occurred if it weren't for Kathy. And in the meantime, I gained a new friend, and I'm very proud of, and I would like to show her a token of my appreciation in front of all of you. Kathy.
I feel like I want to be again.
Okay, so Denny, if you're ready, we're going to have Matt Patterson from Safe Project at Broward House come up, and Matt is going to introduce Admiral Winnefeld's video message just for us.
Hi, my name is Matt Patterson. I work at Broward House. We provide services to people living with HIV or AIDS, including housing, substance abuse treatment. I met Admiral Winnefeld when I was also a client at Broward House, and I just started school using the homeless tuition waiver, and I met them through their collegiate recovery outreach programs. And I can honestly say, if it wasn't for the work that Safe Project does, thanks to Admiral Winnefeld and everybody at Safe Project, I probably wouldn't have stayed in school. It wasn't the easiest thing at the time, and I was really appreciative. And Admiral Winnefeld couldn't be here today, but he provided a video. So here's Admiral Winnefeld.
Greetings, everyone, for giving me the opportunity to speak briefly to you today. My name is Sandy Winnefeld. My spouse and I are the co-founders and co-chairs of SAFE Project, which stands for Stop the Addiction Fatality. Like many organizations working in this space, SAFE Project was founded in a tragedy as we lost our son Jonathan to an accidental overdose in his dorm room on his 4th day of college. You can imagine how devastating that was. We decided to throw our lot to trying to prevent this from happening to other families. And turning that grief into action, we looked back on our journey and through our research and started our work in 5 distinct areas with 4 distinct audiences. In our Safe Communities initiative, we partner with localities across the nation to create and share sustainable and comprehensive ways to respond to the addiction epidemic with resources that are bridging prevention and recovery, which facilitates change and transformation by breaking down silos and better coordinating prevention and recovery efforts to improve outcomes for people. Within those communities, we also focus on tailored resources for kids in our Safe Choices program to reinforce the important anti-stigma message and build strong prevention efforts. Our Safe Campuses program collaborates with college and university staff to assist in prevention and recovery efforts and provide mentorship and support for students to succeed in the lifelong journey of recovery. And I have to say, seeing our own Matt Patterson, the person who went through our Collegiate Recovery Leadership Academy as a student fellow, mentor, group leader, and eventually a student representative, witnessing Matt contribute to a pillar in an event like this is a joyous scene. We also work with our military veterans and the Safe Veterans Initiative, where the aim is to promote wellness and stability through the challenges and hardships that accompany service and separation from service for both the service member and their families and caregivers. Our Safe Workplaces Initiative works directly with businesses, organizations, unions, and leaders to provide resources and education and to ensure people are supported through their recovery journey and their wellness. And we're now piloting an aggressive and we think sophisticated social media campaign oriented towards getting our most important messages on addiction and overdose prevention out to the most important audiences. Throughout my military career, I had the honor of working with many different people with different skills and different strengths. That directly translates to SAFE, to everyone in this room, and to the whole reason we're here today. So we're honored to be with you and wish you the very best in your important work. Thank you.
Well, thank you, Matt, for coordinating that video, and hopefully, could you guys turn the lights on that side? Thank you. It's our first year doing this, since we don't have a light person. Let's see, I was just going to give you a rundown of the afternoon so you know what's coming up next. So the next panel that's coming up is evidence-based responses. And then we're going to have a panel called Novel and Promising Strategies. And then we're going to have an afternoon break for those people in the room who like ice cream. Ice cream break for those that ate their cucumber salad. And then we have our prevention strategies panel, and then the very final one is about creating positive public and private partnerships. Each one of the panels is going to be about 30 minutes or so, and Dr. Lloyd is going to coordinate all that, or moderate all that. So if I could, I'll call up the panelists for our next panel. Let's see, this is evidence-based responses. Frank Rubito, Dr. Tom Smith, Wendy Comack, Emily Piper, Catherine Schramm, and the Honorable Ginger Lerner Rennie.
While they're getting out here, I'll keep with my tradition of starting with a story. This one, what we're getting ready to tackle is probably one of the most controversial things we'll talk about around medication-assisted treatment. And when I got here, there was a very nice reception last night that I got to attend, and I really needed that. Night before last, I was in a rural county in Middle Tennessee, and we were talking about bringing an MAT clinic to this area. It's the second worst area in our state, and it's one of the highest rates of neonatal opioid withdrawal syndrome in the entire United States. And the zoning in this city is zoned to keep out what we do. It's actually unconstitutional because it violates the Americans with Disabilities Act, and you can't do that. But in order to overturn it, you have to get them to turn you down and then sue them. And so we went before their planning commission, and the whole community turned out. And I'm saying this in response to our video this morning because the overriding thing of that video was stigma. Guys, this is how stigma shows itself. The community got up one by one and said things that frankly my church would be ashamed of. And one lady wanted to make sure that the zoning was just so because she didn't want, quote, these people getting too close to her church. And so I'm a bit of a smart aleck, and I said, I'm not really sure. I must not understand the New Testament. I must totally miss that altogether. And I try not to get started when we talk about that. You think about the treatment services that are denied for things like that. These people are people in our community. It's Chris, good looking, guy should have been a model that we learned about this morning. So when you see these people, guys are talking about us, they're talking about me. So with that said, we'll go down the line. If you'll just a quick introduction and we'll get started.
My name is Catherine Schramm. I'm with the Cook County Sheriff's Office out of Chicago, so thank you for having me. I am the program manager with our co-responder program. Our team name is Treatment Response Team, and we do what's called the co-responder virtual assistance program.
And good afternoon, everybody. It's so wonderful to be here. I'm Judge Ginger Lerner Wren. I am the county court judge here in Broward, the 17th Judicial Circuit, and pioneer of the first mental health court in the United States.
Hi, my name is Dr. Tom Smith. I'm the Director of Behavioral Health at Care Resource, which is an FQHC or Clinical Health Center in Broward County and Miami-Dade. I am also over the first syringe exchange in Broward County, the first legal syringe exchange.
I am Emily Piper. I'm Chief Legal Compliance and Advocacy Officer at Hazel and Betty Ford Foundation. We're the largest nonprofit in our space across the country in 9 states, including South Florida. We also have a graduate school where we train the next generation of professionals responding to mental health and substance disorders in America. And I have to say, this panel makes me feel like I'm completely unqualified to be up here, so I appreciate the opportunity to talk.
My name is Wendy Kalmack. I am the CEO of Brillios, and we are a clinical stage biotech company. We have formulated a drug for the treatment of acute polydrug withdrawal. And so I myself am sober 37 years. I am one of these people, those people. Sure, my mother never thought when I was a hot mess for a decade that I'd be sitting here today.
Thank you for inviting me. My name is Frank Rubito. I'm the Chief Operating Officer for WestCare's Florida operations. We have programs in Pinellas, Pasco, Broward, Miami-Dade, and Monroe County. We also provide behavioral health services in 17 other states and 4 U.S. territories. Thank you.
So I want to say with our program, we're a co-responder where both disciplines are equally important, and here's my person.
My name is Efren Lott. I'm with the Cook County Sheriff's Office in Illinois, just like Catherine, and I'm the director of the treatment response and our sheriff, Tom Clark, created back in 2000.
All right, thank you. Yeah, just if you look at open abatement and how the money needs to be spent, or a good roadmap for it, 4 buckets. All right, prevention, education, treatment. I forget the harm reduction. Sorry, I know right off the bat. Thank you. I felt your eyes burning in the back of my head. So those are the buckets we're talking about, and I really love this segment because we're going to get to talk about some things that are controversial. When Dr. Smith said that he ran the first syringe service program, I was waiting on him to throw the word legal in there because I'm sure they've been going on a while anyway. So we're gonna break from this and start with you, actually, Dr. Smith. Can you tell us about buprenorphine, the utility of it, and then why syringe service programs? People in my community say, "Well, I'm not a drug addict and I'm not a homosexual male, so none of this stuff affects me." Can you talk about that?
I think one of the most important things about our syringe exchange program and about the use of buprenorphine and getting people there is we have an opportunity right now to meet people where they are, to really help people that not necessarily are the ones that would be seen coming in for treatment and whatever it might be. So, for instance, in an emergency room, somebody walks through as an overdose. We now have an opportunity to have a conversation with them, begin to talk to them about recovery, begin to talk to them about what treatment would look like, or just accept them for where they are at that moment. And it's, in some of the emergency room programs that we have, the bridge programs, they're able to get somebody that's onto buprenorphine right away. If someone comes in and overdoses, guess what? They don't want to feel drunk. They don't want to be sick. So if we can get them treatment right there in that moment of desperation, to say you don't have to feel this way anymore, that's going to help them to move on. And one article I just was reviewing, in Journal of American Medical Association, talks about a study in California where out of 500 of the patients in several different hospitals, more than 50% of them that were started on buprenorphine in the hospital were engaged in service with a month from that time. So it is effective in that sense if we offer that, and we can, and you mentioned before about reducing stigma. This is an opportunity for us to reduce stigma. And same thing with the syringe exchange. Syringe exchange, where, we may see people that walk through the doors and they want treatment. We see those people. We're all in this room, see those people. But we don't necessarily have exposure to the people that haven't yet walked through that door.
Yeah.
So the syringe exchange says, guess what? This is an opportunity for you to come in. We're going to give you syringes. You can drop off the syringes you are used. We're going to give you new syringes, and we're going to get you tested for HIV. We're going to get you tested for hepatitis, and we'll be able to get you into care. That's something that's most important if they want it. If they don't, they know we planted a seed. They know where to come. No stigma.
So I'm sorry I've deviated from our program, but if you look at, I hate this term, but everybody understands it. The lowest hanging fruit we have, I think, are in three places: jails, prisons. Those two things are different. Hospital, emergency departments, and that's why I wanted to start off like that with this. And then the place that could have the most impact is actually criminal justice, particularly when you have a judge. And so we're going to go in that order. So, Catherine, I want you to talk about the utility of buprenorphine and what you're looking at with the incarcerated population around that Black Matters. The right person?
I don't know.
I'm missing Catherine. No, I'm sorry, Catherine.
Yeah.
Is that good?
Yeah.
Did you miss the question? Okay, I was talking about, it's okay. I thought I said Catherine. I might not have. Looking at MAT in the jail and why that's important and what were the barriers to getting it there?
So I'm not sure if this question is appropriately geared for me. Our program is in the community, so with law enforcement. I can talk a little bit about that response and what that looks like.
That's what they had down here. I thought that you had a jail program. I'll fix that one later. Go ahead.
We do have jail programs, but those are not ones that we operate in.
Sure.
But thank you. So a little bit about our co-response is that our law enforcement officers are able, when they respond to any mental health or substance use related call, they are able to utilize our team in a virtual setting to provide immediate support, de-escalation, and connection with services. So what we find is that when officers are on scene, an individual, whatever the case may be with the incident, is that if they're wanting treatment, there's a small window of the opportunity to act on that. So our team is able to help support our law enforcement officers in getting them connected with services virtually immediately and getting them where they need to where to go to get connected.
Does that hookup for treatment come right then or after they're processed, and then to kind of walk us through how that works?
So a little bit how it works is a lot of the individuals that are officers respond to a scene of a overdose or a mental health crisis. A lot of them are not being sent to jail. They need to run. So what's happening right there is they're providing them virtual assistance. What we seen during the pandemic is that telehealth works. So our officers have or cell phone. They connect them with our clinician, and then get them treatment right there for the immediate action that's needed. Safety planning, maybe recommend them go to get evaluated at the hospital, and then do the follow-up. And people that are, say for instance, in a violent situation or a domestic battery case or something, we do in turn go and work with the family or the situation. And also, if the individual was incarcerated, we'll get them or arrested at that time. We'll get them.
I want to tell you why these first two are so important, is to give you an example of what the real world stuff. In Knox County, Tennessee, we actually looked at all of our overdoses for a 2-year period. And we went back and we traced how many touch points we had with each one of those people who overdosed. Blew me away. Really, you only need to listen to 2. Everything after that was just like those first 2. 20, 30 times. Law enforcement, judges, hospitals, overdoses in the EDs, all these touch points. And then we scratch our head when they overdosed at the Knights and in East Knoxville. Right? It was predictable. We all knew it was coming. When you start talking about programs like this, you're talking about intervention at the time it happens to break that cycle. That's why it's of paramount importance. So, Judge, I'll come to you. I'm a huge fan of mental health courts. I'm not going with this question. Tell us what the heck a mental health court is and what you do.
Well, I think we know very well, tragically, that our jails and prisons in the United States, serve as our largest de facto psychiatric hospitals. And, credit, really belongs, I think, to a courageous community that back in the early 90s, we recognized for the first time, I wasn't on the bench then, I was actually working for what is now known as Disability Rights Florida. I come out of the disability rights space. And, we recognized that we had some real problems in the jail in terms of overrepresentation of persons with serious mental illnesses and co-occurring substance use disorders, in our jails. And basically, essentially, a couple of things were happening. There were also suicides in the jail. We know that suicide is the #1 cause of death in our U.S. jails. And we recognized that people were either revolving endlessly through jail, through the streets, into hospital acute care units, back into the streets, back into the jail, or in the alternative, that people were being trapped in the jail, that judges and lawyers just did not know what to do. They didn't know how to identify mental illnesses. We didn't know what to do with them. They didn't understand what they were looking at, what they were seeing. There was no training or courses in law school on this. And so in Broward County, a task force, an integrated task force was formed, and they met for years. And the beauty of this behavioral health criminal justice task force was that for the first time ever, two parallel independent systems, one being criminal justice, mental health, and behavioral health, came together to solve complex problems. And they met for years, and I think there wasn't really consensus. I wasn't on the task force. I was working at South Florida State Hospital, monitoring a federal class action, as many of you recall. And but they did finally, in a moment of frustration, it was our former public defender Howard Finkelstein, who basically knew that we had a drug court, out of Miami-Dade. He knew there was that model. And when our lead chair, Judge Mark Spicer, said to him, basically, what is it that you want? Howard's response was, I want my own bleeping court, meaning a mental health court. And they knew I was coming. I had just ran and won without opposition, thank goodness. And so they were looking for a judge coming on the bench with specialized skill sets. And I did have specialized skill sets, because what I was monitoring at South Florida State Hospital under the federal class action was really a very complicated consent decree, but I was following individuals in their discharge planning processes all across basically all the catchment areas of South Florida State Hospital. And that was a very large state hospital back then. I think that there were 2,200 beds. Wow. Now there's like 325 or something to that. And so it was really downsized since then, as with most state hospital systems. But yet, I was trained by the leading experts in the United States on all disciplines of mental health, systems of care, psychiatric rehabilitation out of Boston University Center for Psychiatric Rehabilitation. And, when you think about discharges, for example, from hospitals, and you think about discharges from jails, it's no different, right? It's no different. The same principles apply. They have to be individualized. They have to be qualitative, right? There has to be somewhere to divert to, hopefully. But yet, I think we were able, with the incredible, just the incredible buy-in from all of our agencies, and Paul will remember this, that were asked basically to serve this court that had no budget. We still have, we never got any grants. We were the model for the Federal Law Enforcement Mental Health Act that came out of Ohio legislation. But our community had to basically reconfigure their service systems to serve our court, and they did. And so since then, I think our diversion, they hit the jail. It's a post-booking model versus CIT. That's a pre-booking model, right? You look at your SIM map, you know where we fall. Intercepts 2 and 3 on the sequential intercept map for those who are into that. And I'm also a professor, so I'm teaching SIM also to my graduate students. So I just think that this court really follows a logic model. The idea that treatment works, the idea that we have to turn a courtroom into a classroom, the idea that we need to promote mental health literacy in everything we do, the idea that we have to integrate the evidence-based through court process so people understand the ACE study, they appreciate trauma. We use a human rights framework. Human Rights Watch spent days with us observing the court, and we are actually part of a recommended strategy of the 2003 Human Rights Watch ill-equipped publication. I think we're like footnote 26 or something like that. So we're super proud of this court. It's a court of dignity. It's a court of recovery, and we've diverted over 24,000 people into the court. We're a global model, and we've been honored at the Hague.
If you want to open the world, attend drug court, attend mental health court, attend safe baby court. We have all kinds of specialty courts now, courts that specialize in trying to keep mommies with babies, which is important. And I promise you, it'll be an afternoon well spent. It cleanses you inside.
I mean, therapeutic justice, is so beautiful. It's beautiful to implement as a judge. It's beautiful to practice as a lawyer, and it's just beautiful all the way around.
And one of the things the judges that lead these things never tell you, it's all volunteer. They're not getting paid extra for this. This is work that they're doing outside of their normal dockets, which when I got in there first was completely insane and crazy. Mr. Rubito, we talked at lunch with several different people about the importance of families in the recovery process. And it's been my experience that they're left to flounder in the wind for the most part. What I've seen in my time in addiction medicine. Can you tell us how you all integrate the families into the recovery processes and support services you have for them?
Thank you. So the Village South, which is one of WestCare's agencies, or right here in Broward County, provides residential services to women and their children. We've managed over the course of our 50 years to figure out a way to integrate services to these individuals, both moms and babies. I might add that in my 20 years with the village, I can only recall one child being born testing positive for drugs. So if a person gets to us early enough, treatment does have a significant impact and outcome. It kind of morphed over the course of the years we've been engaged in services to women, and that goes back to 1992, with SAMHSA giving out some of the first pre and postpartum and pregnant grants around the country as a result of the crack cocaine epidemic. Some of what we see today with opioids is very similar to what the country experienced and what Florida and South Florida experienced with crack cocaine. We've kind of morphed over to a population involved with the child welfare system. It didn't take long, but it did take a little while for judges in the dependency courts and those that work in child welfare that there is an opportunity to have a safe place where both the mom and the child can be in a safe therapeutic environment. We've had as many as 7 children come with a parent. We do our very best to make sure that there's adequate space and room for all. So the child welfare and dependency piece of what we do is extremely important to us, and I know it's important to the community. But interestingly enough, there's something wrong with the way in which referrals come. And on any given day, we can take more. We're not seeing the volume, but we're glad to be in that space. We then do a great deal of work on the diversion side. So with the new federal requirements for child protection, it's steering children and families away from the deeper end dependency system. So we're involved very heavily in a lot of diversion work here in Broward County with ChildNet and the managing entity. So that's kind of where we're at with families. Our follow-up model is in-home on-site, or if it's Medicaid, therapeutic behavioral on-site services. We do not see people in our outpatient program, whether they're leaving from residential or whether they're coming straight to outpatient in the office. We don't want to see anybody in the office. We go to where the person is. So it's home, sometimes it's school, sometimes it's work, sometimes it's a Saturday at the park, but we don't do anything in the office. And we found that to be a very important model for dealing with and engaging families in individuals' care, because we see the person being served in the environment in which they live on a daily basis. We can then engage the parents, siblings in a person's recovery. That isn't easy to accomplish the way in which the financial structures of behavioral health work. They don't work that way. It's not a family cost center in which you can bill. You're billing for individuals. So you've got to kind of figure out ways in which you not only can get paid, but you also can engage a family in a person's rehabilitation and recovery and keep them resilient to relapse. So I've got a lot of opinions on funding and financing and how it contributes to the demise of our operations. But it is what it is, and you've got to be creative and you've got to find ways in which to engage families, because if you don't, then the likelihood for a negative outcome post discharge from residential anyway is not good.
Frank, we never would have guessed that you had strong feelings about it. But I appreciate it. And I think the remarks are spot on. Emily, you said you didn't know what you were doing up, but you're up here for a really big reason, because I know of very few things policy-wise that have changed the landscape like the Samaritan 911 law.
Well, I was reflecting on some of the big policy changes that have happened in our space over the last 20 years that really have tried to address the structural stigma. Because we talked a lot about how people experience stigma, but I think one thing that doesn't get enough attention are public policies that actually create barriers for people, not only inside systems, but across systems. And that's why it's so exciting when in Florida and other states, they have safe harbor laws for people when they call 911 when somebody's overdosing, that they know that they're safe from criminal prosecution. I know, I have 3 teenagers, and I say that experience is like living with low-grade anxiety, worried about your kids, ruining the rest of their lives based on one decision they make every single day. Kids at parties, kids overdosing and then being scared to call 911 because they don't want to get in trouble. They don't want to have consequences. These are real life stories for people. There are other structural barriers, like making sure that we have extended health insurance coverage when people leave jail so that they can continue to have insurance to pay for the recovery. There are a myriad of different ways that public policy can influence a better future for people with substance use disorders and mental health conditions at the state level. We talked about zoning ordinances at the local level, at the federal level, and ultimately what's going to be required, as it always has been in our space, is people showing up and telling their stories. And so it's you all telling your stories about how you experience people suffering every single day, your stories about the beauty of recovery, to really change public policy and ultimately public mind around the disease of substance use disorders and mental health conditions. So really thrilled about the changes to Safe Harbor, and frankly, that's just the beginning.
And so what this looks like in the community, to put it as, what we see, you have people overdose and the people with it would slam some ice cubes down their pants and leave. Okay, or roll up in front of an emergency department, open the door, roll it out, and take off. How long did it take them to drive to the emergency department? You got about 6 minutes when you go down before your brain starts to irreversibly get damaged. And so laws like what Emily's talking about have been a game changer for us, where people can call, get help there ASAP, because time is tissue. Tommy's tissue and tissue here we're talking about his brain. So thank you so much. And I'm going to let my friend Wendy close, give her the last word because, and Wendy and I've talked about this numerous times. When's the last time that we got a patient in and we did an initial drug screen? And I'll ask the cops this too. We only saw one drug. I mean, I can't remember. I mean, it's been eons. I mean, it is basically the kitchen sink. And then there's some stuff in there that I don't even know the test for, like xylazine, that is negative because I don't even know what I'm looking at. So, Wendy, what's new on that front? Because this is what I see every day. And I'm going to tell you one problem I have with clinical studies. They've got all of these things that they kick people out for. If they have this, they don't qualify for the study. Those are all my patients. The ones you kicked out with all these other, those are the ones I'm treating. So I don't have something clean that you have in an academic setting.
Yes, which is why we develop drugs in a silo and then they don't work when we do clinical screen, right? Because we don't know what they're going to look like in the real population. I think I was a thought leader even when I was an addict because I was using a lot of drugs back then. So I mean, that's, you know, and along with a lot of those drugs came a lot of physical problems, right? I had peripheral neuropathy, I had chronic fatigue syndrome, I couldn't sleep, I definitely had bad anxiety. Why did I have all those? You know, everybody's busy telling me it was an issue because if I really loved my family, certainly I would have stopped. And I'd like to think I'm a smart girl. My ex-husband might not agree, but I will say that in 1986, when I sobered up, I went to the library because it was the only place I could go to figure out, why do I have all these other problems? Like, I was a relatively healthy, incredibly active kid. Why do I have all these problems? And now I can tell you why, because now that we're doing drug development and we talk about the complexity of this disease, it is far more complex than just a dopamine reward system disorder. Yes, we have an issue with the nervous system, and dopamine's included in that, and midbrain dopamine, but we also have glutamate toxicity and all kinds of other things that are going on. But then there's an issue with the immune system, and there's an issue with the cell metabolism and mitochondria, and then there's a dysfunction with the liver. It is, if you think of withdrawal, like a biological grenade going off in the body. Sit here and think about the last time you had the worst case of the flu, and I mean a 7 to 10 day flu, and now multiply it by 100. Okay? And think about how impaired you were, and then now think about, oh, I need to come up with a strategic plan for my life and execute flawlessly. Well, that's what happens when you go into withdrawal and into treatment. And so our drug had a couple of criteria. First, it had to be safe, because I wasn't going to be the commercial on TV that had, you know, hi, we'll get you through withdrawal, but then you have a brain bleed. No, that wasn't going to work. The second piece was it had to be deployed, to Steve's point, into the real world to see what does that look like. It has to be inclusive and not exclusionary in terms of the real world and what happens. And thankfully for us in our first trial, we collected an extraordinary amount of data per patient to establish then 9 different mechanisms of action that give people, with the exception of xylazine, because we don't know yet, because we're testing that now. But in terms of short-acting opiates and any other things and any combination thereof, it does a incredibly promising job of mitigating withdrawal, retrain sleep patterns within 48 hours. So you might imagine that having a patient that's really engaged with you early on in treatment planning. See, I don't know how you guys are, but I don't like when people tell me what to do. So like, I didn't do very well in treatment when they tried to tell me what I needed to do, because I was incredibly combative and argumentative. And so this removes like that, because this allows the patient to return to a level of stability rapidly, which is important, because right now, buprenorphine and other MAT are very good tools in the toolbox, but high potency fentanyl, you're in withdrawal in 2 hours. We need something that works fast, and Stevie said something that was really important. We can't wait to do physicals and stuff on people and biopsychosocials. We have to give them something right out of the gates, preferably like right when they're pulled into like a jail situation. Our drug is a swish you swallow. It's super easy for the patient to do, so that we get in front of withdrawal symptoms and they don't experience it, because whether they're going to go to jail or whether they're going to go to court or whether they're going to go into treatment subsequently, we want them to feel better, because when people feel better, by extension, they do better. It is just a human trait.
Thanks, Wendy. It's so important.
By the way, we are collecting real world evidence for FDA, because you might imagine they do have a real struggle with how do you design a trial for poly drug, and this, everybody's got different things in their system. So we're gonna get on the streets of Nashville with Steve. I'd love to be on the streets down here. We need to grab real patients and to treat them and collect that data through a world registry. So we have that data for FDA, because, you know, doing drug development's like pushing lava uphill. And this just makes it more complex. And this isn't like cancer where we dumped a bunch of money into it. Stigma still prevents money from like VCs into this drug development space. I know, I sold my homes, everything I owned to fund the drug development. So.
So if you look at treatment overall, we're talking about feeling better, getting better, staying better, right down the line. Panelists, thank you all for your work.
So panelists, if you could go to the left, and Kathleen and Dr. Lloyd, if you could join them for a panel photo. Thank you very much to all of our panelists. Let's give them one more round of appreciation. So we have our next panel coming up, which is novel and promising strategies. And then we're going to take that break that I described a few minutes earlier, but may have slightly oversold the ice cream. I know. You told me as soon as I got off stage. So it's very decadent chocolate, smoothies, chocolate strawberries. It's beautiful. So it's still good, but sorry about that for the ice cream faces. So if we could have our next group of panelists come up to the stage. Stephanie Davis, Al Johnson, the Honorable Judge Michael Davis, David Sharp, Dr. Cipriano, Sherry Thomas, and Darwin Richardson. So this panel, you scoot out of the way here. Sorry about that. So this panel being moderated is novel and promising strategies. Dr. Lloyd.
All right, everybody. We're getting closer to being on time. In this section, we're going to look at interventions and strategies that we know work, and maybe explain a little bit about them that you didn't understand. I think the biggest change that I've seen in my time in addiction medicine has actually been in criminal justice with the specialty courts that we're talking about with drug courts. But then we're going to cover some things in here that are outside of those, although they will be in here as well. So as usual, we'll start from left to right. If you don't mind introducing yourself, a quick one-liner.
Hi, Sherry Thomas, Director of Youth and Family at Henderson Behavioral Health.
I'm Stephanie Davis, Deputy General Counsel of the Legal Services Corporation.
Good afternoon, I'm Al Johnson, Chief Assistant State Attorney in Palm Beach County State Attorney's Office, and I run the Sober Homes Task Force. The civilian side is now called the State Attorney Addiction Recovery Task Force, bringing what I consider silos together and making a difference through legislation and innovative programs.
Hi, everyone. I'm Michael Davis. I'm a circuit court judge here in Broward County, and I preside over the county's criminal court.
Good afternoon. I'm Darwin Richardson. I'm the CEO of Utopia, and we're based in Austin, Texas. We are a DEA licensed and FDA licensed facility manufacturing controls, and specifically that's cannabinoids and psychedelics. We actually have the distinction of doing the first FDA approved cannabinoids.
And I'm Rob Cipriano. I'm a board certified police and public safety psychologist. Been practicing for 22 years. I'm licensed here in Florida, California, and North Carolina.
I was afraid the stage should qualify. Dave Sharp, I'm the Executive Director of Community Programs with the Broward Sheriff's Office. Also chair this county's community response team, our opioid community response team.
Also happen to chair the United Way Commission on Drug Prevention and Education. So I'm going to trash some of these questions and go with my own. I'm going to start with my friend Al Johnson. And Al, it's not going to be anything that's on the sheet. So if we look at the money that's coming into our system right now, it's also going to be ripe for fraud because it is a ton of money. The biggest need anywhere I go is housing. Housing. And I met Al several years ago, and when Al told me what he did and I learned from him, I was amazed. Because Al is who I guess I give credit for what other people do cleaning up the housing mess here. Al, would you talk about that and how people are preyed upon with some of the actions that you guys took to remedy that situation?
Sure. 2016, the legislature was trying to figure out what to do. The opioid epidemic was getting out of control. And they did what legislatures do. They kicked the can. They went to Dave Ehrenberg because Palm Beach County was the epicenter. South Florida, Palm Beach County, Delray Beach was ground zero. And they said, hey, start a task force, which in bureaucratic speak is, again, kicking the can down the road. But Dave took this seriously. He tapped me to oversee the task force. We created two. We created a law enforcement task force. In the last 6 years, we've made 121 arrests of providers, road providers, sober homeowners, felons, and we pretty much cleaned up on it's supposed to be never going to be 100%. Perfection is the enemy of the good, but we changed it a lot. Y'all from Broward, BSO, try to talk Harold Primer just starting a task force. Okay, we've been trying, but just okay. So anyway, one of the things we've done, we've been able to successfully pass legislation 6 out of the last 7 sessions, and we have legislation that's poised to the floor this year. Much of the legislation, not all of it, is to enhance DCS, the department's ability to oversee, and the other is to be able to pave the way for organizations like Oxford House and FAR to be able to come into the space and not be the good citizens with their torches and their pitchforks closing them down by fear. As you all know, I'm sure, when you have a certified recovery residence through FAR or with NAR standards, that's really top of the line. At Oxford House, the same way. Studies have been done on the Oxford House. So what we've been able to do and accomplish is this is an unbelievable thing. No state comes within 30% of the 9,000 plus beds that we have certified in the state of Florida through FAR. And Oxford House didn't exist here 4 years ago. They now have 1,500 beds in the state of Florida, over 10,000. And that's the key. Everything is the key. But you talk about drug courts, you talk about MAP programs at the jail. You talk about, we have an innovative program that we've supported and we're able to get through called the Addiction Stabilization Unit, which is a trauma model for hospitals. The thousands upon thousands of overdose responses by fire rescue. Where are they going to go? They're going to go to a hospital with no peers. They're going to go to a hospital with no addiction specialists. And they're going to run out of there and relapse. But now we have a model that's been replicated 12 times through the state where you have a warm handoff. You go to a hospital that has the staff, board certified psychiatrists, peers. They move them over once they're stabilized into the Addiction Stabilization Unit, which is the Palm Beach County Healthcare District. Okay, so these are the innovative programs that are going to, writ large, create solutions. And I'm proud to say in Palm Beach County that we've reduced our overdose deaths from opioid 19% from year over year, from 21 over 20, and then another 13%, 22 over 21. This year, our stats show that we'll be down another 4%. This is while generally the whole state is going up and up and up. So housing. You have to have a place to live where there's not a drug dealer parked outside waiting for you to trigger and relapse.
If you listen to what Al's talking about there, he's talking about a system of care. so many points there that other parts of the state of Florida are losing patients when they drop out guys to go to the street and die. Translate that really easy. And those hookups and warm handoffs to treatment are key. And I thank you so much for that. Judge, we'll go to you. You already know my feelings on drug courts. I'm a huge fan. Tell me what your experience has been, because I've yet to meet a judge that runs a drug recovery court that it's not the highlight of their week.
Awesome. Thanks so much for having me. And I have to say that I'm not here by myself. I'm not here alone. I got to give a shout out to my team who's here with me, my village, without whom we couldn't do what we do every day. Dr. Lord, before I answer that question, I'm going to ask one of my own. And it's going to sound like the start of a joke, but it's not. I liked your turtle analogy. So I got another one for you. Does anybody know here how you move an elephant? My kid, he really likes animals. We watch the Discovery Channel all the time. We were watching a show and they had to move this sick elephant in Africa. How the hell do you move an elephant? Right? It weighs 10 tons. Every person that is suffering from addiction has got an elephant on their back. How do you move that elephant? You can't move it alone. Not possible. The only way to move that elephant, those 10 tons off somebody's back, is with a group. Judges, lawyers, law enforcement, social workers, physicians, peer counselors, and the numerous other hundreds of people in that village that come together to try to move just one elephant off one person's back and say, here's help. Let's give you a hand at this. So that's what I get to do every single day. I've been a judge for 8 years, and I have to say, as Dr. Lloyd intimated, this is my most meaningful assignment on the bench. I'm just going to spit out, I'm not a numbers guy either, like Dr. Lloyd said, but I'm going to spit out a couple of facts and figures at you. Broward County's was the third established drug court in the nation. Our drug court was established in 1991. We established our pretrial interventionary court. In 2008, we added to that a post-dispositional court. That sounds like legalese to me, so I'll try to dumb it down. I have to dumb it down for myself. Right? Pretrial intervention is when an offender commits an alleged offense, drug offense, or a likewise offense that may qualify them for entry into the drug court, such as a theft-based offense, right? Stealing a thief and habit. They're routed into our diversionary drug court and are required to complete a very difficult, very rigorous substance abuse treatment program, but with arms of both the judicial system and the community system to wrap around and help lift that elephant off their back, right? Now, our legislature recently just made an important change to the law. Recently, there was a requirement that a person had to participate in the drug court program at least 1 year. The legislature has deleted that requirement and has handed the discretion back to the judiciary, which I think is appropriate, because this is not a one-size-fits-all course. Every person, every participant is different and individualistic. Now, our secondary portion, which was added in 2008, the post-adjudicatory portion, is where folks who have committed offenses that may not qualify for them for drug court, violent offenses perhaps, but still are struggling with that demon of addiction, have been sentenced to prison, but are being given another shot, diverted from the penal system, and placed in the mandatory drug court program. Their backs are to the wall, these folks, very much so, because their only alternative is a term in the Florida state penal system, which is not a pleasant place to be, nor treatment focused to folks who are suffering from addiction. Now, that's a smaller program. We only have 29 participants in that program at this time. I just came into the drug court. I was just assigned about 4 weeks ago after a 4-year stint in the family court. And if you think I didn't see any addiction in the family court, we can talk about it. My goal is to increase that program by leaps and bounds, because I think that everyone in this room, including our friends in law enforcement, district with the state attorney's office, do not want to see offenders that are struggling with addiction issues sitting and rotting in jail. Right? We don't want to see them sitting and rotting in jail. So our whole job, our entire focus is to reach out that hand and help. That's what I do every day, and I love it.
Thanks, Judge. For reading just because there's so much good stuff up here. I've known David Scharf now for several years. And David, I'm going to ask you to piggyback right off the judge and talk about pre-arrest diversion programs from Broward County.
Yeah, thank you, Dr. Lloyd. I want to just start off by acknowledging some of the people in the room who are part and parcel to these diversion programs. Our deputies here, our SID deputies to my right. The whole reason that we exist, in part, the whole reason we developed these programs is because what you just said. We understand that there are a whole bunch of bad people who need to be in jail, but guess what? There's a whole bunch who don't need to be. So we've established co-responder program in our county where deputies like this and our wonderful peer specialists who are here will both be deployed out to a site where someone's in distress and the throes of addiction, with the sole purpose of guiding them in the right direction, whether it be treatment, back to a recovery residence, or a respite program run by Rick Riccardi, where they're safe for a while. The whole premise of destigmatizing this issue is lives. And we've been successful at it. We're going to reach out to other cities within our community. We're also so proud to have our comrades from Cook County here talking about utilizing technology to be able to deploy as much as we can. The other thing I'm going to talk about real quick, it's kind of not pre-arrest diversion, but it's what we've been talking about, is this bridge program where our peers are deployed to our hospitals. So no one leaves that hospital who came in as a result of an overdose or addiction without some help. And I always say this: if you break your ankle, you go into the ER, they wrap it up, put a cast on it, maybe tell you to go see your orthopedist the next day. Not so true. Someone comes in with an addiction or a substance use disorder. Now, in all of our major hospitals, there are peers there available 24/7 to help guide people in the right direction. Very proud of that. It's not an easy feat to do, so congratulations. Thanks, David. We'll start to tie in what we're doing today. Our very first session that we had was on data and analytics. And if you listen to what David just said, start to think about some things we can measure. Recidivism rates, right? We can do that. Repeat hospital visits. We can actually put a tangible number on these and show that our interventions are working. And when I talk about measuring stuff and doing stuff and working, this is what I'm talking about. So Dr. Cipriano, we're going to jump down to you, because I would like for you to talk about compassion fatigue and how you address that in first responders. So just to give you an idea of what that is, we have a first responder goes out, they reverse somebody, they go into the hospital, 2 hours later, they're back on the street. And they have to reverse them again and take them back to the hospital, and it goes on and on and on again. My buddies who do this, like Steve, what's up with this? Right? We're missing that piece that Al talked about, which is that warm handoff. So when we think systems of care, that's what Al wants you to start thinking. Thanks so much.
Thank you so much for having me. Just a quick, shout out to Kathy. Thank you again for all the great work that you're doing, and Gretchen right over there with DEA, amazing work. And again, to all super blessed to be here and certainly the opportunity to talk with you. Working with public safety professionals, some of the things that I've worked on, I look at themes. And doing this for 22 years, I was at Miami-Dade for a number of years, and very blessed now to be here in the beautiful city of Fort Lauderdale, and be in the South Floridian, growing up here and really seeing the city evolve, and just all the beauty and just all the good people here that do the good work, the grind every single day. I'm very blessed to be part of that mission, kind of behind the cloak of confidentiality and privileged communication. Working with police and public safety, working with nursing professionals, working with the whole gamut, I can tell you is it kind of really, in my opinion, is predicated on two things. Looking specifically at what may be burning you out. So we talk about compassion fatigue, and we don't want to get into semantics. We don't want to get into being stressed and being kind of drained from stress, right? It's all under the same cluster. So what may be, in a sense, draining you, I think is a really rhetorical question with a statement. And the second thing is, what are you doing to recharge, right? So when you get kind of basic and you don't really kind of get into the lexicon and the language of, kind of complicating things, you really deduce it. I think that's a big part of connecting with people. And that's really what I believe is why we're here, right? To connect. We teach and learn from the time that we're little, right? And working with public safety professionals, I can tell you those themes, a lot of times from the inception of when they actually go through training, you look at the curriculum and not getting into the blame game of FDLE or anything of that nature, because they do amazing work. But I think our culture has changed because of this. This has totally changed the landscape of how we communicate with one another, right? Everything is fast. The hamster wheel, doing more with less, all these different phrases. Well, that takes a toll going back to that basic premise of what's draining you. And if you're not taught to have the infrastructure from the very inception through training, you only succumb to it. So it becomes reactionary as opposed to being proactive. So we're seeing a cultural shift now, specifically FDLE. When I talk to the police and public safety professionals, hey, it's in the curriculum. We're seeing the attrition rates. We're seeing certainly the retention challenges because people are getting burnt out. So when you look at that, you have to kind of look at those basic things and not kind of put our heads in the sand, if you will, to say, okay, all right, wow, what are we doing now with the military, right? What are we doing back when people came back from Operation Freedom in Iraq? We're meeting with them and we're talking with them. And we're trying to get around certain kinds of what I call hiccups. When you're talking to somebody to say, hey, wait a second, is there any kind of secondary gain? Is there middle management, especially with the military? I do a lot of work with the military. We're very blessed to have the most amazing fighting force in the world. But when military reservists would come to me in active duty and say, well, I did have a mental health problem, but my superior basically said I'd have to stay here longer if I admitted it. And you hear those kinds of stories time and time again. And you say, okay, wait, what can we do to kind of negate that? We go back to that basic question. Let's not put our heads in the sand. Let's be real. Let's be transparent, integrity. Let's be honest with one another. What are we doing to address the elephant, burnout? And then starting from there. Now, some of the remedies for that, very basic. Are we looking at traditional treatment? Are we looking at evidence-based practices? Are we looking at other aspects, hobbies, interests, things that may have kind of gone by the wayside because everything else has become a priority? So I think those are things to kind of ask your question. Certainly don't want to take any more additional time, but just really looking at those two key themes. What's draining us and what are we doing to actually, in a sense, recharge? And I think once we kind of get to those core aspects, whether it's the artichoke or the apple, right? Getting to the core of it, I think that's really where we empower that individual to stay connected with somebody, a trusted professional, under that cloak of confidentiality. They can say, hey, you know what? I'm having a problem and I need help. And that's really where this begins and continues. So
thanks, Dr. Cipriano. Any program I go to that has Stephanie Davis at it, I'm always fired up because I learn something every time. And I know she probably didn't know who I am, but I love her explanations and things. We talked about the Good Samaritan law. You can touch on that a little bit if you want to. But we would like you to look at novel and promising strategies you see with legal services.
Don't get a piece of technology to
yeah, we're gonna have.
Okay, thank you. Okay, that's so much better. Thank you, Dr. Lloyd. So I work for the Legal Services Corporation, which is the largest funder of free civil legal services to low-income people living in the United States. We have We have 131 grantees that serve every state, the District of Columbia, and all of the territories. And our grantee down here is Coast to Coast Legal Services, who also works with Legal Aid Services of Broward County to serve this area. We're kind of, what our grantees do is sort of the counterpart to the criminal justice system. So when you think about civil legal issues, those are things like housing, family law cases, custody, guardianship, consumer debt. Those are the kinds of things that our grantees help with. And I was thinking about the judge's discussion about the elephant and how one moves an elephant. And you do it all, everyone has to do it together. One of the things that the civil legal aid providers do is they help remove roadblocks to moving the elephant. So what's an example of that? Say you're a person with a substance use disorder who has been charged with a crime, who has a criminal conviction, and loses a professional license as a result of that, or is incarcerated and incurs court fines and fees, or goes into arrears in their child support payments. Going into arrears with court fees and fines and child support payments can cause that person to lose their driver's license. So now if they don't have a professional license and they don't have a driver's license, it's really hard to get employment or to be able to go get yourself to recovery. Those are civil legal issues that a legal aid attorney or a pro bono attorney or a private attorney can help eliminate. So they can help pull those roadblocks out of the way and help a person get back on the path to stability. Also, very similarly, if you have an employer who is working with someone, either they have them on staff or they're thinking about hiring them, but they learn that they're on medications to treat their opioid use disorder and realize that person's on drugs. I'm not going to hire them, and that's the only reason. That's unconstitutional, or not unconstitutional, sorry. That's a violation of the ADA. That is a civil legal issue that an attorney can help address. So that's what our grantees bring to the table. That's how civil legal aid attorneys can help in the parts of the network that can address the issues that you all hear about every day when they're talking about needing to find a guardian for their child in case they are going into a treatment center that doesn't have their kids. Civil legal aid attorneys can help them figure out what legal processes need to be followed, if any, to get another family member or a friend to have the legal authority to care for that child while they are in treatment and allow them to do that. There are lots of ways that attorneys can connect with the other parts of the recovery system, and the one and two that I kind of want to highlight are engagements with treatment providers, recovery providers, or healthcare systems. How many people here are familiar with medical legal partnerships? Cool. No, I know. This is going well. No, but medical legal partnerships are great. They are exactly what they sound like. They are arrangements where lawyers are embedded within a hospital or a healthcare center, and they seamlessly integrate with the treatment team, with the social workers or whoever else is working with individuals. They train the medical professionals to recognize legal issues, and then they are there to either accompany a social worker to a patient who has a simple legal issue, or they can get a referral from a medical professional. That's not the only setting where medical legal partnerships or where lawyers can work with medical professionals. Another one, and I'm pleased to say that this was one of our grantees in Kentucky, the Appalachian Research and Educational Defense Fund, or AppleRed, developed a program where they were sending out an AmeriCorps fellow to recovery centers throughout the state of Kentucky to do intake screenings, identify people who had civil legal issues, and then provide them with legal assistance. So they helped approximately 60% of the people that they interviewed with getting their criminal records expunged. And getting your criminal records expunged again is removing a huge barrier, because if you don't have a criminal record, that causes landlords, employers to look at you differently, and makes those kinds of stabilizing services more available to you.
Thanks, Stephanie. And I want to thank you personally, because I've called your group a bunch of times and they always help me. So I'm grateful for that, helping me and helping my patients. Darwin, I'm going to save you for last because you have absolutely the coolest stuff. Okay, so sorry, I'm not saying that you don't. Right? That wasn't my comment. Sorry, you all have a lot of programs. The one that I always get interested in the most, and you can cover what you want to, but mobile response teams. I think that, yeah. So if you don't mind.
First, I think at the memo when you're on panel, don't work us. Those of you know, we know what to do. So when Gary asked me to talk about rapid response, that was a topic I thought, and I felt like, even though he did a bait and switch on me and what I should talk about, he said that one, I was all in. So what we know about our most deep and complex behavioral health, adults and children, is that when we take a deeper dive, we see that many of them have had Baker Act after Baker Act, they've been arrested, been in and out of the hospital, treatment centers, and they haven't had services in between. So we know that if they don't have services from one Baker Act, very quickly, we know the likelihood of getting re-Baker Acted is pretty good. And so when it comes to rapid response, we need to look at those ways to make sure how do we get immediate access to the people who come to see us. So Henderson takes that part really, really serious, and we're really very much focused on trying to provide rapid access. And so I'm really in charge of youth and family. I don't know that much about the adults, but I do know enough to share a little bit about our CRC and our system to know that we take, so our Henderson, what we did in response to wanting to be very responsive around that strategy is we went for the centralized receiving system. So in that system, we have this centralized receiving center, we have detox, we have the CSU, we have our mobile crisis response teams. But each and every one of those, we do actively trying to make sure there's rapid response. So in our CFC centralized receiving center, we see about 400 people a month, 17 of which come from law enforcement. And one of our goals, I know, is to get the officers back on the street within 10 minutes. And I hear that we're doing really good on that strategy. Those folks who come and see us 24/7 can get immediate access to what they need, whether it's at Henderson, and if it's not at Henderson, we will get them linked out into the community. In fact, we created a policy recently about a no wrong front door at Henderson, where you can go to any one of our 51 programs, 22 locations, and if you walk in and you're in the wrong site, then every single one of our employees knows that we have to say whether we can serve you or not. We're going to do a screening to figure out what it is that you need immediately, and that we're going to send you to the right person, the right branch at Henderson, and if not at Henderson, somewhere in the community. And being at Henderson 30 years, transparently, I know we didn't always do that. There were times if someone walked into one area that we didn't serve, and we would say, oh no, sorry, you're in the wrong place. So we no longer do that, and we take it very serious to make sure that no matter if you're calling us, answering, logging in, that we're going to get you to the right location. As far as mobile crisis response teams, we served 1,500 families. We assessed 1,500 people last year. Our diversion rate from a Baker Act is about 75 to 80%. That team is made up of clinicians, of peers, of care coordinators, of navigators. We are very invested in getting out to where we need to be within an hour, as much as possible. Broward County traffic is a little crazy, but we know how important it is to get there immediately. And back in the day, they might leave the home after they stabilize a crisis and then make some referrals to families or to different providers. And it felt like I'm going to refer to every provider I know. And it was almost like throwing spaghetti at the wall, wherever it sticks, it sticks. So we have changed our practice so much that we won't just make a referral on behalf of you, or we should not. That team needs to be making referrals with the families, with family voice, figuring out where do they want to be referred to, what services do they think they need to have a better life, and then it's not up to us to decide where we're going to refer them. And so we have purposely changed that practice very much over the last few years to make sure they were getting what they need at the right time, and that we're not taking a one-size-all-fits approach. What else? Mobile crisis. Did I hit it all? Alita? Miss Alita? Okay, got it? All right.
Thanks, Sherry. Just with each piece we add, you can start to see how it fits into the overall treatment scheme and not losing people through the cracks. And I know we're a little bit behind, but in all fairness, I got started a little bit behind, so I'll take up for myself.
One more thing.
Absolutely.
Just for Larry's sake, he's going to talk about it, but on our youth side, also we go out of our way to make sure that whatever we look for funding for, it's going to be a funder that's going to fund services that are going to get out of those silos, and that we could go in immediately and break down like the funding, like, oh, Medicaid lets you do this, but this funder only lets you do that. And so Child Med has been very flexible to work with, and we've created really good programs that we're having great outcomes, and it's based on there's no wait for services. They don't let us have a wait list. We want that to be in our outcomes, that we can't have a wait list. They have to get to people within 24 hours, and so we want to see that kind of accountability put on the providers because we see that it's working really well.
The last thing you want in an emergency is to be put on the wait list or tell you 3 days, right? So Adara, we're going to close with you. Really good stuff. And when I first started learning about this, I had to turn some certain things off in my mind and open myself up to looking at data. So it's all yours.
So thank you. It occurred to me, our mission is alleviating suffering and transforming lives, and being here, hearing everything about substance use disorders fits squarely in our mission. I mentioned earlier that we make psychedelics, and that probably got a various myriad of reactions. I got them when speaking with people individually. But what's exciting about the psychedelic space is it treats 3 key areas. It's mental wellness, it's also working with substance use disorders, and you also see efficacy in brain injury. So 2 of those areas we've already talked about here today, and that's mental wellness and substance use disorders. So if you're not listening to the data or looking at the data coming through on psychedelics, you need to pay attention. There's some really interesting tools that are coming to you that will be available, and that's right in our key space. We have 2 tools that we can offer to the toolbox utilizing cannabinoids and psychedelics. And for example, a lot of people don't think of Delta-9 as perhaps a therapeutic product. Our product today is approved for nausea and vomiting in chemotherapy in these patients, not at a psychotic level that induces, a high, but at doses that are lower than that. But that same approach can be used in opioid sparing or tapering strategies. And that adds again to the toolbox of buprenorphine and so forth, things that need to be used there. Could that be a modality that would be of interest? We have a phase 2 asset that's ready to go in with a meter dose inhaler. So not a process that would require needles, injections of any kind. So it changes that stigma around that as well. When you look at psychedelics, we're currently working with many companies in the space around bringing their molecules through clinical trials. We're developing those drugs. We're doing the drug development. We're making the clinical material, and we're helping them provide, that are in that space. We have many of, or pretty much all of the psychedelics stood up, and especially the 2 that really have shown promise in substance use disorders are ibogaine and DMT. So you might have heard of DMT, dimethyltryptamine, as ayahuasca. That's probably the common name. But both of those molecules have shown early data that demonstrate huge efficacy for substance use. That's methamphetamine, that's opioids, that's alcohol, etc. And so we were talking earlier about treatment of addiction. What if you can prevent relapse? What if you can have a tool that gives you the ability to have a high percentage of stopping relapse? That's a game changer. From everything that I'm hearing today, is now you have something that takes if you're able to stop that, maybe you can even stop it earlier before you actually have issues. And if that's the case as well, then you may not need as much of the infrastructure. That money can be put upstream. The efforts can be put upstream to actually stopping these things before they get to the market. So I was asked to give some thoughts that might be controversial and get some thinking. What if you changed and moved the treatments into the jails? Moved it way upstream. Can you set up an infrastructure there? And, one of the things we learn in the manufacturing environment is what they call lean operations. You don't touch a piece of paper 5-10 times. You move it to touch these lines. But when it occurs to me when we're talking about patients here, we're moving them through a system, and how many times are we touching them? Is there a way to change that paradigm, touch them earlier upstream, and help them cure perhaps, right? Another thought is what if you take and create like a public-private partnership where you now have drugs such as buprenorphine and naloxone, and you take those profits from that, you have them within your communities, and you redirect those profits into those communities to sustain those programs. Because again, this is out of the box thinking. People don't think this way. You hear this from class of drug companies. But why not partner in those situations where you can take those drug funds and then sustain a program that gives you the ability to have profit and a sustainable income revenue. And this, we have a finite period of time to find a sustainable solution. And then where else, what do we do with the additional money and keep requesting money? We got to change the rules of engagement. So let's create a sustainable program. One other thing is taking if we're cooperating among different counties, and then you have transparency, you're sharing the data, you're also sharing whether or not the drugs are effective. And that then gives you the ability to say, okay, this is what's working here. This data proves it out and says, okay, this is how it's working. And then if you bring that into a clinical program within moving a product to the FDA, you can then tailor the clinical program that fits with what's needed with the actual infrastructure that you already have in place. Drug companies today now take, they create the drug, they create the way that it needs to be deployed, and they give it to you. You have to fit that in your infrastructure. What if you were part of creating that clinical trial and the way that those materials have to be used? Then the clinical trial is done in that manner, in your own community, with your own infrastructure, and that's what's approved by the FDA. Let's say you improve on that, find better ways of doing that. You take the same data that you have, you take what's working, and then you use that for phase 2, and you get additional indications for that. And that's looking outside the box on these public-private partnerships. And so I'm bringing that out. I'm trying to give some additional ideas. But if you took UMP, for example, you were able to put profits in additional investment and take the profits into UMP, it now causes gives you the ability to prevent addiction. Where else can that money then be repurposed elsewhere? Can you, instead of arresting someone, can you get out there and early on, wow, I see that you started using, let's stop you here and now. Perhaps even DMT could stop in that prevention early on if you catch it. So I'll stop there.
Thank you, guys, and thanks to our panelists.
Thank you, panelists. If you guys could all go to the left and get your picture. And Kathleen and Dr. Lloyd, if we could have you also. So there was, we just wanted to make sure that we acknowledge before we break. We wanted to acknowledge 3 people that we work with in that way very closely on this, and I hope that they'll stand and you can show them your appreciation as well. Angela Ventura leads the team at the commission at the United Way. She's over there in the corner. Angela, thank you for that. And she has 2 fantastic people on her team. France Million back here in the corner. Teresa, I said, Teresa, could not have done that without those 3 people. So we want to make sure we gave them a proper praise.
So we're getting ready to take the break, but I was absolutely mortified that I, in my rushing around, did not get any thank you from Gary, because with all of us, we have just had such fun doing this together. So I'm very good at reading minds, and I happen to know that Gary really wants to see the mind reader that's appearing at the Riverside. So here are 2 tickets to the mind reader. For indulging me. So break, take a break. It's, yeah, outside, 10 minutes. We have amazing homemade desserts for you outside. Oh, homemade desserts, so.
Thanks, Gary. Just a quick reminder before we get started. You've got flyers on your table for the 9th Annual Mental Health Behavioral Conference, May 14th and 15th at the Broward Convention Center. This is done in partnership between the United Way of Broward County's Commission on Behavioral Health and Drug Prevention, collaboration with Broward Behavioral Health Coalition and the Florida Department of Children and Families. There's a session that you're hear from keynote speakers. We have emergency use available for licensed clinicians and certified patients. So we've got those flyers on the table. All right, it was a short break, but we are really close to being back on time. You know, a lot of times when I'm out doing conferences, I get busted for talking about medication, and I told you I do that because it's controversial, and it's really not controversial when you're looking at housing and food sources. It's kind of hard to argue against those two unless you just don't have a heart. But what I really am is I'm a prevention guy. We're not going to arrest our way out of this. We're not going to treat our way out of this, but I think we can actually start to prevent our way out of this. So with that said, we are going to look at prevention strategies, and we're going to lead off. Actually, can we go down and just introduce everybody real quick? Just bring them on. Introduce yourself.
Larry Ryan, CEO of Child.
Good afternoon, Cindy Ehrenberg Seltzer, President and CEO of the Children's Services Council. Brown.
Hi, Dr. Rachel Dosical, CEO of Hanley Foundation.
Hi, good afternoon. Maria Hernandez, Chief Program Officer for United Way of Broward County.
Thank you. Hi, I'm Debbie Hickson, one of the countywide school board members.
Hi, I'm Tracy Suffolk. I'm the Senior Director of our Safe Communities Portfolio at Safe Project. You got to hear from Admiral Winnefeld earlier. We help families and communities mitigate the impact of substance use. And I'm Susan Nyamura. I'm the CEO of South Florida Wellness Network, but most importantly, I'm a woman in long-term recovery.
Yeah. And for the families, we got to keep your comments to about 4 minutes or so. When you see me stand up and get close, I don't want to hurry you, but I have as much interest as anybody in getting out of here on time. I have a plane to catch tonight, and I want to make sure that I get to Atlanta, although I have a bunch of lawyers waiting on me there, so maybe I want to get stuck here. So we're going to start off with you, Larry. Could you tell us what campaigns you're finding successful in impacting families and children, and then what challenges are you facing as an agency?
All right, thanks for asking the question. I'll answer the way I always answer, the way I want to.
Of course.
And I apologize, I'm going to run because I have a doctor waiting for me at Commercial Boulevard at 2:30. But when it comes to prevention, and Child operates the foster care system in Broward and Palm Beach counties. So basically what I know about is prevention of child abuse, abandonment, and neglect. And I got two sort of important messages. One, evidence-based practices, prevention practices, serving families in Broward County have absolutely transformed the foster care system. We used to have those services funded predominantly by the Children's Services Council have resulted in a decrease in the number of kids in foster care in Broward County from 4,000 when Child Net started to 1,300 today. And I see my friend Dave Sharp there, and you'd be remiss if I didn't say this, and others from BSO. The other piece of that is getting families to those services, and that was the job and the tremendous work of the Broward Sheriff's Office up until recently. So very important, evidence-based practice is crucial to prevention and serving families. But my other message here is, we cannot become slaves to evidence-based practices. They cannot be the only thing in our armament, the only arrow, we also need to have, and 2 panels ago I came in and I heard the gentleman from the village talk and somebody else, Dr. Nexdale talk, and they hit on a couple of things. We also need to be flexible. Not all evidence-based practices necessarily meet the families that we need to serve or the children we need to serve. And if we don't recognize that, we make big mistakes. ChildNet invested heavily because of the success of the Children's Services Council on doing evidence-based practices with families that are already in foster care. So it's worked, but it doesn't work as well as something we do with Henderson, which is a homegrown program we've been doing for 20 years called Family Placement Preservation Program, PPP. That's how we always talk about it. And the key to that program, flexibility. They do whatever the family needs. You know, you hear people talk about meet families where they are, and you truly meet the family where they are and stay where the family is. And it's not evidence-based. That said, if we're not using evidence-based practices, we need to develop the evidence of the programs we use. We can't use them just because they feel good. We can't use them just because we like the people that do them. We can't use them just because they've been successful in the past. We need to continue to develop the data and the outcomes to prove that they are effective. So to really solve really complex social ills, we need to do both the very well structured evidence-based practices, and we also need to be incredibly flexible and responsive to the people that we serve. Thank you very much.
So Larry gets now my new favorite panelist. Again, like the earlier, the other panelists, it's hard to tell where Larry comes down on things. So thanks, Larry. Who's going to get to you next? I know what we have here for you, but I want to ask you something in addition to that. How does South Florida Wellness Network develop and disseminate overdose prevention informational materials? And then how can duplication of efforts be reduced? When we see this all the time, you have multiple people doing really good things, but it's overlapping. So we want to try to reduce all that we can. And I'd also like you, if you could, in your time, just to touch a little bit on your work with the National Federation of Families. Something that I have just discovered in the last year that has really made an impact on me. And I think that we'd be remiss if we didn't get to talk about it just for a second. So please.
Sure, absolutely. So I think it's kind of funny that I'm on the prevention panel, and especially with the question with regards to naloxone distribution and the duplication, because there's obviously not enough naloxone being put in people's hands because people are still dying, right? Or at least they're not educated enough to really fully understand really what it's about. And I'm also a little biased because I don't think anybody does the kind of work that we do at South Florida Wellness Network. We're on the ground day in and day out. I don't know how many calls we had this weekend. I think there were 7 in one day. And they started from 2 a.m. and they went all the way through the day. And that's the responder model that we have with Broward Sheriff's Office. And we're really out there educating people on the harms of the contaminated drug supplies. The reality of it is, don't say no, does not work. Right. It kills people because we need to educate people that there are a lot of contamination in our drug supply, and most specifically with our children. I also am a parent of some young children that are in the Broward County school system here. I think prevention starts a lot younger than where we're at. I think if we started prevention from probably this age and part of the social determinants of health, we wouldn't be in a lot of the places that we're at. But I still think that naloxone is an important aspect of it. But one of the things that we notice that families are really, really super important in this midst, because as a parent, I learned that my children could not keep me out of jails and institutions. There was nothing, absolutely nothing that they could do. But I know that as an educated parent and as somebody in recovery, that I can do everything that I possibly can to keep my children out of jails and institutions. So, thank you. So Federation of Families has been something that we started with in Broward County, which was back in 2014. It's our 10-year anniversary this year. And we started working in the systems of care because of the amount of young people that were getting Baker Acted, and how important it is for families to have a voice in the care that their children were getting, and how even more important it is now today, because we're serving a lot of those families and the youth that we have in the programming. Kayla, Amber, our youth programming, they're in the schools. We're getting overdoses now in middle schools. It shouldn't be happening. There should be more families in here. Families need to be educated and they need to be told what's going on. And people need to be loved. It's like somebody came around, they were asking me to leave a message in Spanish, and we were like, I don't speak Spanish, I speak German, I speak this. Love is a universal language. And I think we need to start loving our community a little bit more.
Yeah.
Yeah, thanks, Stephen. I love the work that you do with the Federation of Families. That is it's a fun place to go. When I got up here this past summer, I was pretty down. Again, I've been beat up a lot. And I got up there and I thought, man, there's a lot of really good people still in the world. And again, one of my favorite terms, it got me up and I was ready to get back to it. You know, we're going to talk about Narcan distribution and overdose prevention here for a second. I'm going to say something that may ruffle some feathers. Now, Narcan is not prevention, guys. That's bringing people back from the dead. Prevention is stopping it before it ever starts. And we need to be talking about programs. And Susan just reminded me of that. About 10 years ago, I got called from Hawkins County Sheriff's Department, Forest County in the state of Tennessee. And the sheriff said, Steve, I want you to come down here. One of my deputies had to go out to Rogersville Elementary School. And we had one first grader teaching another first grader how to crush up a Lortab. All right, so that's 6 years old, guys. I keep hearing prevention, middle school, high school, the horses left the barn. Most of the kids that I deal with, their first drug use, guess who? Their parents. It's with their parents. It's early on. So we need to change our mindset. Before we get into the, we do have some stuff around Narcan. But maybe one of the things, we're going to talk about public-private partnerships here in just a second. Tennessee, we're the second worst overdose state in the country, only behind West Virginia. You never want to be in the same sentence with West Virginia or Mississippi, and we are. All right, so we're there. You got about 56.9 per 100,000. West Virginia, just to give you an example, one spot above is over 90, which will tell you how bad it is there. But with that said, we look at Narcan distribution in the state spends a lot of money on Narcan distribution. It's impressive. We're still second overall worst. Why? There's a lot of barriers to getting the Narcan in the hands of people who need it. I don't need it at the health department who nobody goes to.
Right.
I need it in the hands of people who use drugs or people who are around people who use drugs. And if we're not doing that, then we're not being effective. And again, it goes back to measurement. How do you think probably state agencies measure? Is the Narcan out our door? I really don't care about that. I care about Narcan in the hands of people that's going to be around first responders to overdose, that's going to reverse an overdose. And so it's just not about getting somebody's, nitrous in the wine here. You're doing a good job, but you've got some restrictions that we don't need. Either get rid of those restrictions or we need to put some programs in place that get the medication in the hands of people who need it. And that's the whole point there. It reminds me of when Tennessee was playing Florida in football in the 1990s. We were better than them every year. I don't care what any of y'all say. And we lost every year in 1998. At the end of the game, we would always say, well, we had more passing yards. We had 500 passing yards. Yeah, we got beat by 35 points. But that's the problem. The problem here is you say, we've got all this stuff in place. You're still second worst. Right, so we have to look at removing those barriers. So with that, I am going to jump. I thought I knew where I was going to jump. Sorry. Oh yeah, Deborah Hickson. So Deborah, would you mind talking about school districts using outside partners to host or contribute to community events to support overdose prevention awareness? And the reason I want to talk about this is I've had trouble getting overdose reversal drugs into schools. And it's like, well, I don't want to put the idea in their head. All right, or we don't need to address that for whatever reason. So I'd love for you to talk about that.
Thank you. And I'm going to put a little plug in while I'm here also because we partnered with BSO and there is a town hall next week, Tuesday, March 5th at Plantation High School. And it is about the dangers of drugs and alcohol in our community. I have a little flyer. And the school district does partner with BSO in a lot of different ways, and actually different partners. But I last year hosted a town hall on fentanyl use for the community with BSO. And we did have Narcan distribution there. And I did have the issue of the school district saying, no, we can't have Narcan at the schools. We worked on that and now we can. So but then it's weird because the nurse can't have it, but the SRO officer can. So it had to do with training and things of that nature. But we do now have someone who carries Narcan on the school campuses so that if there is an issue, which unfortunately, as you just mentioned, we're seeing that even in elementary schools. There is someone who, for the Narcan purposes, is there able to distribute that. But we try very hard to partner with a variety of different people to provide education to our families. So we do town halls, as I mentioned. We had the fentanyl one, and we had a variety of people. United Way was there, BSO was there, some of the people in our district was there. There was a whole panel. There was a mom whose son had died of a fentanyl overdose accidental. He bought a pill online and he took the pill and he never woke up. So that's really important for our families to understand that you can have fentanyl delivered to your house in the mail. And you're not gonna know that you're you know, it was just curious, his friends were ordering these things and it happens more often than you think. And I got a lot of pushback about doing the fentanyl town hall because we don't have any fentanyl deaths in our student population. But Broward County is one of the #1 places for fentanyl deaths in the state, as I learned when we had the town hall. So it's important that it doesn't have to just affect our students. If it affects their families, then it is incumbent on us to make sure we're educating the whole family so that it doesn't work its way into the students' lives. We also, our chair, Lori Alhadeff, has done a number of town halls on vaping because, as I'm guessing you probably know, vaping is a huge problem in our schools. And again, that starts in middle school. So we need to make sure that we're educating our parents. There's all these things that you buy a hoodie and the vaping thing is inside the hoodie. And, you know, then there this past year, highlighters are vaping pens look like highlighters so they can bring them in school. And they're sitting in the back of a classroom vaping because you can't smell it, you can't see it. And if they're in a crowd of people, nobody really notices what's going on. So it's very, very important that the district partners with families, but also nonprofit and government agencies to do these town halls. And we are doing that. We're doing it in different areas. We did it online. The one that's next week, you can either show up in person at Plantation High School or you can go online to get the information. So it's very, very important that we continue to do that. So if you're a nonprofit or a government agency and you have an idea of a town hall you'd like to do, please reach out to any of the school board members. You can reach out to me or any of us. We all are very interested in making sure that we keep our communities and our students safe. So thank you.
Thanks, Deborah. And just Cindy, I'm gonna make you last. I have the hardest question for you. So I'll let you sit there in the room for a while. You can come here and see how that goes. Like Larry did and just answer what the question you wanted me to ask. All right. So Maria?
Yeah.
I got you. So can you tell us what United Way is doing to support the development and dissemination of overdose prevention communication campaigns by implementing public and private partnerships?
So, the United Way Commission on Behavioral Health and Substance Abuse, which, you're all familiar with us. Our main goal is to increase community resiliency and to increase protective factors across the spectrum. Something that if there's one thing that you want to remember about what I'm saying today is that prevention is treatment and treatment is prevention. Just because the system of care and government and others, had labeled and had divided how the type of intervention individuals and community need in order to do better, that doesn't mean we have to do that. So yes, there's just a way that you do billing. There's a way that you need to document how you do things. But prevention is treatment and treatment is prevention. It depends where you see up front. So for us in the Commission on Behavioral Health and Substance Abuse, it's all about creating protective factors. It's about creating resiliency across the whole spectrum of life, not only for those that have not been exposed to substance abuse or behavioral health conditions, but also for those that are already experienced that. So for those that are, dealing with a substance abuse situation and so on. So we do a lot of things to promote the work that we do, and it's no one answer to our work. We don't answer with just one approach. Our approach is very, very diverse. From events like this one, that thanks to the volunteers, the amazing community partners that we get to put together, to our behavioral health conference. About 9 years ago, we started the behavioral health conference. We get about 14 speakers, about 38 workshops in that conference. It's the first one of that nature in Broward County. We are committed to that conference. And for those of you that have been there, you see that if you were to go to a conference similar to that one, you had to pay from $800 to $1,000 for a ticket
Yep.
Our conference is about $100, and that's because of the United Way commitment and our community partners commitment to underwrite the cost of that conference. Because to us, we know that education is the key to prevention, is the key to treatment. So, again, our approach is very diverse from events like this one, our behavioral health conference. About 4 years ago, we realized that in Broward County, about 30% of the population is speaking of the language, mainly Spanish. So we decided that we wanted to do also a conference for parents 100% in Spanish. So for the 4th year, we have done the conference, and the one for this year was done 2 weeks ago. We have over 400 parents on a Saturday at 8 in the morning. The starting time for the conference was 8:30 in the morning. At 8 in the morning, the room was full, ready with parents that are eager to learn how to prevent substance abuse in their families. So we do events like those. We created now a new task force and conference for Creole speaking parents. Again, bringing the message to our community in the language they understand. The cultural aspect of that they understand, that it's not us telling them here's how you do it, but let's do it together. Let's talk about this, have the conversation and discussion about behavioral health and substance abuse prevention. So we do that. In addition to that, thanks to the support of a lot of our donors and mainly the Broward Behavioral Health Coalition, we conduct every year a huge media campaign. And our media campaign, it encompasses everything from, the traditional media. We have TV shows, we have PSA, we have a partnership with iHeartRadio where, our PSAs are like in more than 10 different radio stations across Broward County. We do the bus benches, we do billboards, we do poster review, putting gas in the gas station. I don't know if you've seen those little TV that have little commercial there. We have commercials there, a little bit of everything. In addition to that, we fund multiple programs. United Way of Broward County and the Commission, we fund about 150 programs in this community. About 20% of those programs are in the school, educating the children about behavioral health and substance abuse prevention. We do a lot of town hall meetings. We have a community training initiative where every month we have minimum 2 trainings to the community completely for free. So it's a little bit of everything that we do. I would say that it's not only United Way and the Commission on Behavioral Health and Substance Abuse. One of our number one strategy is that we are a convener. We convene the community. We bring all of the other partners together, other funders, and we say, okay, let's work on something. Let's work, like 2 years ago, we said we want to work on suicide prevention. For our behavioral health, the Children's Services Council, right away, they said, okay, let's do it. And we were meeting and then figuring out how we're going to do this. And we launched our Suicide Prevention Coalition. So it's a multitude of programs and initiatives that United Way is able to lead in order to prevent overdose, in order to educate the community about substance abuse prevention, about suicide prevention, about behavioral health promotion. But we don't do it alone. It's an entire community that's behind us doing that.
I think you get an appreciation for how many different folks are sometimes working in the same area, and then how do you coordinate those efforts? Tracy, how does Safe Communities help support development and dissemination of overdose prevention and communication campaigns here in South Florida? Oh, sorry, I've got my glasses on, I need to put them on, sorry.
Yeah, so this opioid settlement money is really like once in a life. And it's really important that it's going to public awareness campaigns, but that's one component. Where it really needs to also go is to through systems change. And these are systems that have failed a lot of people. And we all talk a lot about collaboration, all the collaboration, what we're doing, but what we see nationwide as a project is how prevention and recovery systems are still operating in silos in communities. And that's part of the systems change. Prevention is a great partner to recovery. prevention, understands data-driven systems, they understand funding, they understand strategic planning. And recovery specialists also understand trauma-informed care. They are great at bringing people to the table, which is critical. And they are also wonderful at getting goals accomplished on the ground. They're wonderful partners for each other. And it also can help to build a lot of capacity in the community. So we've developed a program called Bridging Prevention and Recovery, which was developed by people in recovery at the forefront, as well as communities. It's been tested across the nation. And we have a training of trainers as well that we bring to communities, because we all believe our approach at Safe Communities is really that communities are the experts, and you all know your communities the best, and they want to hear from you. So we have a training of trainers that helps you upscale this framework. It's a model that's been developed based upon the strategic prevention framework and incorporates all the elements of recovery capital as well. And the other thing I wanted to say is a lot of times when communities are working together, sometimes you get stuck. This is a huge problem to wrap your arms around. And if you're ever not sure what to do, we do have a free platform. It has over 80 different strategies for supporting response efforts in your community. It's called Your Safe Solutions. So I encourage you to check that out as well. And all the other resources that we have at Safe Project.
Tracy, thank you. You hit on something there that always gets my attention, and that's trauma-informed schools. And so we got to have the time. So I think this is really important, because this is a big prevention thing. You want to know who the kids are at risk. Ask their school teachers. They'll tell you. Growing up in East Tennessee, I was physically and sexually abused in my home. What kind of student do you think I was, kindergarten through fourth grade? All right, my teachers knew my name on the first day of school because they had talked to my teacher from last year who had already done their time with me. And so back then, when you acted out and you were treated with corporal punishment, right around the edge, paddled in front of multiple classrooms, and that was Stephen Lloyd. I was also put into slow classes all the way up until we took a standardized test when I was in the 7th grade. So that's the life that I lived. What was happening to me in my home? I was being physically and sexually abused. All right, so there's a reason for that acting out. So there's some elementary schools around the country. I'd encourage you to Google them. They have a trauma-informed curriculum. It'll give you hope for the future, guys. We have one in Nashville, West Nashville. It's one of the highest incarcerated zip codes in the United States. And when you go there, the entire teachers, right down to the staff that serve in the cafeteria, are all trauma-informed. They have a trauma director that trains the trainer kind of deal with all the teachers. It's pretty amazing stuff. And I think that's when we really start moving. So thanks for bringing that up. Outstanding. And I'm still saving on to you. That's it. All right. So you got your Stickle? Did I get it right? And you're the hitter. Stickle, we're talking about the single biggest investment that my practices have made in the last 10 years have been in peers, because of how important they are. It takes sick people who have gotten well to help sick people who are still sick. It just does. And so I would like you to talk about the importance of peer support led programs for family members.
Sure. Let me start with Prevention Works. Hanley Foundation, in partnership with many people in this room, Children's Services Council, United Way, we are the largest provider of prevention services in the state of Florida. We are in 32 counties, and we only grow into counties where there are no services. There's so many things that this panel said that I wish that I could jump in and say, we've put 16 Narcan boxes in places like parks and nightclubs in Dixie County. But you asked about peer support. So today I want to tell you about a drug court program that we just conceived and implemented again in rural counties. So we are in Henry, Glades, and Okeechobee. And the way this looks is when there are actually two pieces to this. When a young person is caught with a substance or they're caught selling a substance, they get what we call level 2 prevention. So level 1 prevention is I'm an educator, I go in front of a classroom and I talk about coping skills. I don't talk about drugs and alcohol. You are so right. Just say no just doesn't work. But what does work is to help kids understand that 85% of kids in schools are not drinking and using drugs, and help them understand what it means to have courage or make a good decision. That's level 1 prevention. Level 2 prevention is something that only a couple of school districts across the state of Florida have been willing to pilot. What that means is this zero tolerance policy that so many schools have, which means that kids get suspended or, worse yet, they're thrown out of school. This impacts the rest of their lives. But level 2 prevention and the program that we teach is called Teen Intervene. And here's the good news about it. These teachers who look at this kid who's been caught vaping in the back of the school or back of the classroom, they don't want to give that kid a referral. They think that's a good kid. I'm going to ruin their lives. I'm not going to do anything. I'm going to just turn a blind eye because they'd be thrown out of school. Well, level 2 prevention puts a pin in that. What it does is the child and the parent or the guardian agree to go into 3 different sessions of counseling, one-on-one counseling, 2 with the counselor and the student, 1 with the counselor, the student, and the parent. And then here's the key. Our counselors watch these kids for the next 6 months to a year. And if something else happens, we get them right back into counseling. This program was so successful in Lee County that they actually closed 1 of their alternative schools. Tremendous. So peer support, let me just go back to that. So we have put in place a drug court program in these rural counties. But here's what's great. These schools had a criminal justice academy already in the schools. So this is a drug court for students by students. And it is really, really working. The student who got caught goes in, they're asked to tell their story, they're telling the truth. And then this judge and jury of their peers decide what that community service and other restorative justice package needs to look like. That happens along with mandatory participation in Teen Intervene. It's tremendous, and it's happening in counties not like this county. This kind of thing where people with resources and knowledge get together and talk about the problem, it doesn't happen in these rural counties where we're working. And everybody that Hanley hires lives and works in those counties because there's a trust issue there. Yeah. There's a trust issue. So, I would just like to thank you for, this forum. Let's bring programs like this to our county here. Yeah. They really, really work.
And they're needed.
They're needed. So Cindy, you get the last word, and I trashed the question and asked. So, yeah, so there we go.
Are we out of time?
No. We've done a good job. Larry really caught us up. So if you, this is a question I get all the time, and it's always the one that makes my brain crawl because I don't always have a good answer. How do you recommend that we identify evidence-informed prevention programs? What's the best source? What's the process? And then how do we look at partnering with folks to implement those? I mean, those are the things that I've struggled with. I believe in prevention, but finding the programs is often tough. And for me, finding them sometimes it's just happenstance.
Thank you. That actually was not, I was expecting much worse than that.
I thought it was pretty bad.
No, because, for those that don't know, the Children's Services Council is a government agency created by the voters of Broward County back in 2000. And I have had the tremendous good fortune to be the CEO since it was created. And so when we started, we built the basis of the Children's Services Council on communities that care. Actually, as a result of the work that we had been doing with the United Way Commission on Substance Abuse, we had just looked at that, and as a community, Collaboration County, if you can't tell how much we all work together, we had developed as a community, what are those resiliency factors that we could build on? What are the risk factors that we want to try and mitigate and build a structure around that? So CSC is actually built on the communities that care model. What are the most cross-cutting interventions that we can put in place in the prevention arena? The very first RFP that was done, that was issued on the day that we first had taxing authority, October 1 of 2001, was for family strengthening programs, because building the family was what was the most cross-cutting event. Now, best practices. So how did we start? We were doing literature reviews of what are the best practices out there in any that had been peer reviewed, but not just that one charismatic leader had made a success. What had been seen to be replicated in multiple places, and were any of those places similar in characteristics to Broward County, a very diverse county? So from that, we identified, I think it was 7 or 8 different best practices that were out there. And that RFP said, do one of these models, or if you have a homegrown model, you have to be prepared to demonstrate its success to date, because we have some brilliant people in Broward County. Now that rubric, although we've refined it over the years, is still basically the way it goes. When we put it out in RFP, that's what we say. Here's what we found out there that seems to be most effective. But if you have something local, then tell us what it is and justify that it works. Now that in and of itself is not sufficient, because I can tell you that we want to bring multi-systemic therapy to Broward County, and you can all look at me like I have 8 holes in my head, because 25 years ago, you never heard of multi-systemic therapy. Now, I hope you do know that it exists and that we have it here. So we also say, we will pay, first of all, prove to us when you do this application that you understand what you're applying to do. Because if you've ever funded a program, or some of you who run programs used to think, I'll tell them I'll do multi-systemic therapy, but after we get the grant, I'm going to do exactly what I've always done, the same way I've always done it. That didn't go over very well. So I asked you to prove that you understood the program that you were applying to do, and put money in the contract to get you trained from the experts on the model. Then we look to make sure that there's fidelity to the model that you were funded to do. And we look at the outcomes. Now, to Larry's point about flexibility, sometimes the best practice isn't necessarily the best practice for your family. You find it needs a little tweaking, we'll work with you on that. As long as the basic tenets are kind of in place. If it says you're supposed to do 4 months, but you think this family needs 6 or 8, we're going to let you stay with them as much as you need. We built in flex funds, which allow you, if you're finding that the barrier to that family strengthening program is that they don't have money to keep the lights on, or they don't have food on the table, and therefore they're not interested in higher order dealing with other mental health issues, well, you can use it to pay for the light bill, or put food on the table, or buy the child clean underwear, so that that's not a stressor on the family. So that's how we build it. Now I'm talking about family programs, so that was the very first RFP, but we're in pretty much anything that touches children. we're involved, and but the approach is the same to how we identify those best practices and support you every step of the way. Now, in some areas, there aren't best practices that have been published out there, and we have made them up ourselves. So so what do we do in that case? Many of you may be familiar with our system of care when it comes to kids aging out of foster care. Another great collaborative that this county has worked on together for years. We fund life coaches for those young people. Now, in that case, there was no great model for what to do for kids aging out of foster care. We've since added kids that have had a brush with the law and LGBTQ children who may not have stable home relationships, so they have to transition themselves. But what we did, to your point about best practices, is we looked at the different components and said, based on the research, what are those best components out there that need to exist? And how can we knit that together into our own model? But the key is the constant feedback loop. What are those outcomes? For those of you who are funded by us and you, oh my God, outcomes, I hate them. We're trying to work with you to make sure the value that you see out of that on both the individual with that child and family, and then collectively, what do we need to do differently to bring out better results? And finally, I would be remiss if I didn't say sometimes we lead, sometimes we follow, sometimes we get out of the way. So in this arena so we are definitely in the prevention, in the primary prevention. We're in a bit of what you call secondary. We have funded new diversion alternatives for youth. Was this very second RFP that we did, which are those diversion programs. They're not in schools, although we made it available to the which can, that program that can no longer be mentioned, but they do give kids that second chance. Sorry, I saw time's up.
No, you're good, Cindy. And that's my most dreaded question. So let's give a round of applause for the company. While they're having their picture taken, one more round of applause for our panelists, please. Thank you. And I also want to take a second. I know we're going to do it more formally in a few minutes, but isn't Dr. Lloyd doing a fantastic job tonight? I'm afraid to see his bill. Now, it should be noted, he's here on his own ticket. He volunteered to do this. This is all on him. So we are very lucky. I wanted to mention one thing. A lot of people talked about Narcan in the last couple of panels, and I just wanted to point out that in your bag, you have a Narcan sample from the Robin Foundation. Thank you very much. Kim Cabrera, if you could just stand up and let everyone see who you are. So Robin Foundation is the source for your agency. If you are in need of Narcan, Robin Foundation and Kim are here today to help us with that. Our final panel is the importance of creating positive public-private partnerships. And if I could call the following people up to the stage. Kathleen Cannon, Alita Segrera, Patrick Chapman, Mark York, Natalie Kelly, and my good friend Uta. A lot of you know from DCF, and now she's at FDHA running a show up there in Tallahassee. And Kathy wanted me to mention that all of our out-of-town panelists and featured speakers and guests today, all of them came here today on their own ticket. So that was a gift that we did not expect. All right, the troopers here are still here. Thank you For me, it's been a really impactful day and a day of a lot of learning for sure. We've reached our last panel. You got everybody? So let's start. If you don't mind, you can take my microphone and just a quick introduction.
Good afternoon. I'm Elida Segreda. I'm the Managing Director of Operations of BBAC. BBAC is the funder of most, if not all, those programs that are being mentioned here today. So we do a lot of work here.
Hi, Mark York, addictiontobeacon.org. Earlier about the data technology, but also I'm actively involved in creating opioid abatement programs for states and counties across the country.
Good afternoon. I'm Natalie Kelly. I'm the CEO of the Florida Association of Managing Entities. Many of you all know the managing entities. Broward Behavioral Health, one of them. And I also want to introduce Dr. Christine Caulfield, who's the CEO of LSF Health Systems, the managing entity in the Jacksonville area that's North Florida and Central Florida. And what we do is, I'm just going to tell you the targeted audience, our clientele are underserved and uninsured individuals in the state of Florida. We are a safety net system for behavioral health services.
Thank you, Kathleen Cannon, the CEO of United Way right here in Broward County. Thank you guys hang in there with us. But thanks so much everybody for coming, honestly.
Hi there, my name is Uta Gatzia. I am from the Florida Behavioral Health Association in Tallahassee. We represent approximately 70 nonprofit providers throughout the state who serve individuals with mental health and substance use disorders. So mostly those with Medicaid, uninsured, and underinsured. It's great to be here. I'm from Fort Lauderdale, so I'm so excited to be back.
Thanks, Amy.
Good afternoon. Thank you all for being here. Patrick Chapman. I'm the Vice President of Behavioral Health for HCA Florida. I help oversee the operations of our 16 units, stretching from Pensacola all the way down to Miami.
Thanks, Patrick. And as with the last panel, if keep our comments to about 4 minutes. When you see me stand up, you're getting close to it. Or I'm going to stick my boy back there on. He's going to take you out back, and we'll have some rearranging of joints. Kathleen, I can't have you up here and not start with you because everything flows out of this. What's the importance of the relationship between the public and private sector?
So, all right, so public-private sector, a lot of times we talk about that government can't solve a problem on its own. Philanthropy can't solve a problem on its own. Nonprofit can't do it. Business can't do it alone. So the idea is really coming together, garnering the power of all of that. Businesses, public, private, government, nonprofits, persons served, persons who've lived these experiences together to make big change and to buy big social issues. Now, we're not the best at that, though. This has got to get better. It's something that we need to work on. Synovus is in the house, right? So Synovus is a for-profit bank, but they fund United Way and they fund programs all the time. HCA is a for-profit hospital. You funded this conference or the summit today. Broward Behavioral Health is a nonprofit, but my goodness, they cover, the entire community and the state and all that you do. However, we need more business to step in. We talked about Narcan, the profits from Narcan. What if that did come back? What if we really did what the sheriff said, and he was speaking to the commissioner that was sitting over there? I don't know if you guys noticed that. But his giant budget, what if we carved out 30 million of that budget and really put it towards the prevention? So that would be, again, working together. We're asking businesses, our local businesses, we're Broward County United Way, so we're asking our businesses to invest. We're not talking about donors. We're saying invest in the work that we're doing because it only makes our community better. We can help folks that are most vulnerable and people that are struggling. Your business does better. Somebody will go into your bank and open a bank account for the first time. Somebody's going to go buy a car. People are going to have more money in the community to spend, so tax dollars come back. It's a fund. It's a true economic imperative that we do this together. Affordable housing, we talked about that in another panel. If you don't have safe housing, how are you going to get clean and sober? How are you going to take care of your kids? How are you going to do hunger? So we've got a public-private partnership happening right now for Housing United about investing in building affordable housing for us here. It is healthcare. So we don't have it solved, Doc. We really don't. However, we're all working on it. People are stepping up to the table. We call it like the Knights table. Like, who needs to be involved and invested in this, and whose voices do we need to hear? And often, Wendy, I want to really thank you so very much. Often we don't listen to the voices of families that have been affected by this. And Heather, I'm sorry, who have been affected by this. So that's another voice that we need to hear, but it's critical and it's important. We're working on it here. We're going to do some really great work and we're getting better at it. So Doc, thanks for that question.
Thanks, Kathleen. When I first started going before state legislators, I understood almost nothing about how to approach it. And one of the things that has caught my attention through the years is that when you put somebody from where they were and utilizing all these services and now they're in recovery, not only are they not utilizing those services, they're a tax-paying citizen. Right, and that comes back around. And so I want you to think about, I mean, I get this all the time, well, Steve, we can't do this and such and such, we can't pay for it. And I said, you already paid for it in DOC, Department of Corrections. You're already paying for it, right? So let's start to look and see how we can not do that and then put people back in, where they can start to become productive citizens. So I appreciate that, Kathleen. I promise you, I'm with you. Ms. Segrera, did I get that right? Oh, well, yeah. That's how we do it. So can you tell the importance of public-private partnerships as it relates to BBHC in here in Broward County?
Anyway, yeah, so like Aline was saying, there's a lot more to be done. However, I can take out of my head this phrase, but it's in the second words. So I'm a little impacted by it. But however, we do have some collaborations right now that are working. One of those, for example, is the math programs. We have 10 providers right now. There's 10 providers that work from detox to peer support, recovery, respite. All of them are coordinated. They work through. Person comes to detox. Sometimes they don't go to detox because they get medication assisted treatment. They go directly to residential, IOP, outpatient, all the time with peers. That is a program that's working really well, and I can say that for the last fiscal year, we served over 2,000 clients, and 65% of them ended completed successfully. Again, there were a lot more served. But remember, if you come the first time, it doesn't mean that you're done. Right. So when I say that there were 2,000 unduplicated clients, I'm saying that there was a lot more. Maybe 4,000, maybe 5,000 that went through. These are the ones that are duplicated, went through many providers. So that is a successful example of collaboration of private, public, and different levels of care. Another one is something that's been mentioned a lot today, the correspondent model. That is amazing. And the good thing about what we do in BBHC is that we are flexible and we jump. So we saw that it was a pilot. We created one team, we funded one team. We saw it was working. We're funding 3 teams this year. We move quickly. When something is successful, we move with it. Respites. We are funding respites. People can now fail and go to a safe place for 2, 3, 4, 5 days until they come back to their treatment. We're funding that since I think 4 or 5 years ago, and 6. Yes, and it's just getting larger. So those are examples of really good things that we're doing. So of course we got to do more. And there's a lot, like we were saying, there's a lot more to do, but those are good examples of collaborations. Peers, and more peers. We started with the peers maybe 10 years ago with the Florida Wellness Network. And today, I don't think that we have one program that we fund that does not include peers. Family peers, mental health peers, substance abuse peers, whatever it is, but peers, because those are clearly something that works.
I certainly agree about peers and everything you said, but peers do work for sure. Patrick, the next question is for you, and it's one that has been kind of the bane of my existence for a while. When I got named the chair of our council, I wanted to know about public-private partnerships because in our state, we really struggle with those. It's basically the state government versus everybody else. And I knew that's not going to help us with what we're trying to do. So I called up our former governor. He gave me some tips on how to do that. So I've got you here today as in your role at HCA Healthcare. And I forget, you told me what percentage of the country you guys take care of. It's
overall HCA takes care of 10% of the US population.
So the only system I can think of bigger than that's the VA.
Yes, sir.
And that's right. We're looking at one of the largest healthcare providers in the United States. So what are the challenges you see, Patrick? Because I know this because I've been on the other side of it, and you hear for profit, and then right off the bat, you know, people go a certain place. I know plenty of non-for-profits.
I don't know what you're talking about.
Yeah, I know plenty of non-for-profits that seem to make a whole lot of money and don't do very good work, and then I know a lot of for-profits that do tremendous work. So I'd like for you to address that.
Well, I'll be happy to. I just want to start with thanking what Kathleen said also about the partnerships we're trying to build. And in my role overseeing and working with our facilities of the 16 units that we have, that when I say mental health, to say that most of them are not co-occurring would be a falsehood. Most of them have those issues. You know, it's just nonstop. And the current that we deal with in trying to help these people get on with their lives. You're talking over 31,000 admissions between our facilities, and those that don't get admitted, there's well over 100,000. Wow. But in my 10 years working at JFK North, where I was the COO, helping run that facility there, I can still remember, you know, several of patient or family members looking at me in our emergency department saying, I didn't know where else to go. I had no other choice and I'm here. So in my role now that I've been doing this for 2 years, one of the things I do is I go out to many of these organizations. Susan was gracious enough to host myself and some of our team from Woodmont a few weeks ago. And the main question that comes out of my mouth is, how can I help? Yeah. What can we do different? What can we do better to collaborate with you? Because to the question you asked, Doc, many a times when it comes to a private agency, a for-profit system like us, that the way a legislation or a policy is interpreted, if you're not a 501c3, that, okay, well, just keep doing what you're doing. You're not a 501c3, let's move on. I'm taking care of these patients, and we're going to continue to take care of these patients. We've planted our flag. HCA as a company has made behavioral health its own operating division. Our CEO and president recognizes the need, and our task, my boss's task, and other people in our division is to see how we can help expand that and help take care of the communities we serve. Because I can't remember, like you said down there, we don't want them to go to jail. My goal is eventually, if I can never have a person go through the crisis of coming to an inpatient unit, I have succeeded. And that is one of my ultimate goals, to not have people go through that trauma. To me, that is avoidable suffering, and I will do everything I can to help avoid that for those patients, because they can get a job. They can do things for their community. They can become people who can thrive and have beautiful lives and move on with that. And so that is ultimately one of the goals we want to do. And you can't do it by yourselves. And so I'm picking on Susan again, but all the beautiful work, the great work they do, we don't do. And to be able to collaborate better. As in the data discussion, there's the silos. We're all in kind of our silos, and it's not because we don't want to, it's the fact that we're all so busy, or we're understaffed and we're overwhelmed trying to take care of these patients and these clients one way or another. We have to work together. So when I go and visit up and down the coast all over the state of Florida, one of the questions that comes out of my mouth is, how can I help?
Yeah, and you know this as well as I do, Patrick, that last line disarms a lot, right? I mean, how can I help? What do you need? And my experience with HCA in Nashville has certainly been that. Uda, you're up next. We're keeping Mark, just so you know, I'm saving you for last. Just to put you there, I don't have a hard question for you, though. But could you talk about the importance of public-private partnerships at FBHA in trying to create the system of care that you're trying to create?
Yeah, sure. So it's always a question, and I think everybody here has said it today, nobody can do this by themselves, right? But we do get siloed, and everybody's sort of in their own little mission. This is what we do. This is what we do. So the biggest thing, we work obviously with our members who are private nonprofits, but we also have ongoing working relationships with the Department of Children and Families, which is who funds the managing entities and, takes care of our uninsured, underinsured. We also have relationships with the Agency for Healthcare Administration for Medicaid individuals. And then we work with all the healthcare plans, which are all private organization. And then we bring in lots of other folks that come in and bring ideas to our members, which are folks that are developing new technology around measurement-based care. To your point, Dr. Lloyd, being able to actually measure treatment, not just, weird outcomes that really don't have anything to do with behavioral health care, but actually will give outcomes of the therapeutic process, of how the patient feels they're doing. Do they think they're getting better? So we try to bring that together, and right now it's culminating into our association working really hard with all of these partners to implement the certified community behavioral health clinic model in the state of Florida. And basically, it's a model that prioritizes pretty much all the things we talked about today. No wrong door. You come in, you get screened, you get access, you get engaged, your family is engaged. You're screened for a variety of things, maybe not even just what you came in for. And then there's a care coordinator that's assigned to get you wherever you need to go. And if whatever you need may not be available in the next 3 days, they'll sit with you and they'll stay with you and they'll continue to engage you. Access to MAT, there's certain required services, which is 24/7 access, 24/7 crisis, care coordination, MAT, outpatient. And the linchpin is care coordination. In order to be certified, you have to have the technology to talk to your partner so you can treat a patient collectively. You must have peer support. You must have formal relationships with your community recovery organizations. And the carrot is that you actually get paid for these things, because it is frustrating when you want to provide a certain level of care and you can't, because you can't have that therapist spend an hour on coordinating care. So they don't bill that, you're not getting paid, and now you're losing money. And that's a reality. So you do get paid at a daily rate, that's an all-inclusive rate, and you can, whoever you partner with, it incentivizes you to partner and other people to partner with you because they will also get that kind of a rate. So it builds this really coordinated system of care that's connected through data, real-time data. You know your patient's been, somewhere else. Maybe if they've been hospitalized, hopefully not. But the federal government is putting a lot of resources into this because of the outcomes. They're seeing things like 70% reduction in hospitalization, 69% reduction in ED visits for people with serious substance use disorders as well as serious mental illness. So that's what we're working on right now. It takes a village. It's building flying the plane while you're building it, so it's a little overwhelming. But I'm really hopeful that these collaborations between government, private organizations, nonprofit members will lead to a system of care that's much more receptive, has many more pathways to recovery, and really coordinates care across the entire system.
All right, thanks, Sue. I appreciate your positiveness. Right? I mean, almost feel like we need to end with her. Because there's so
You
many.
said hopeful.
Yeah, it is hope. But sometimes there's so many blockades that, the way that you put it out was just outstanding.
I just realized.
Yeah, that's why I sat in her chair. Yeah, that's right. You're welcome. No. You're right. You tell us.
Hi, good afternoon. I'm Gerard John. I'm the agency director for Brown Addiction Recovery Center. We provide substance use and co-occurring services for adults with all levels of care, from detox, residential, intensive outpatient, and NAP services.
So since you just sat down, I'll go ahead and give the microphone back to you. So can you tell us about programs that you have at BARC that you like highlight?
So speaking with it takes a village to help these clients struggling with addiction. Recently, we partnered with one of our divisions. It's called HOSTI. It's Homeless Initiative. So as you know, sometimes we have a lot of homeless people, and at the bus terminal, we have an outreach program. So for example, last week, we partnered with them along with Fort Lauderdale Police Department, Task Force, Brown Health Point. Brown Health Point pretty much is like a mobile hospital. And so we partnered with them. So we went in to the streets to educate the homeless, provide Narcan distribution. And what we did was we carried a team from BARC. It's comprised of nurse, caseworker, licensed therapists. So we actually educated the clients, the residents that were on the streets. So we provided medical care for them. They had showers that they were able to take. They were fed. And we actually met with the clients on the streets, provided a screening, and we worked with the task force to transport them directly from the streets into our detox unit, those who met criteria. Because as we saw, once you have that gap between making a referral and giving them a referral to get services, they jump straight from off the street to in our services. So right now we're tracking them. We had one lady that was a 67-year-old woman. She was on the street, critical in fetal position. And we asked her if she needed to get some help from Broward Health Mobile Unit. The nurse came out to refuse services. She refused any of our services. And I was walking back and forth on the sidewalk, and I said, this is somebody's mother, somebody's sister, and she was yellow, probably with jaundice. She had nothing but 2 t-shirts, had medical issues, substance use issues, because when I was speaking with her, she had the slurred speech. So what we eventually had to do, we had to take her out. So the paramedics came, transported her to the hospital. As we're working closely with HOSPI, that division in Human Services Department, to track her so that she does not leave the hospital and discharge back into the streets. So the goal is to work with her so that she could possibly leave the hospital if she meets criteria to come to BARC. So it's critical, the services we provide. Residential is the same thing in Coral Springs. We have a lot of indigent clients that come into care. So we're partnering with Broward Health Point. So the bus comes once a week to residential. So the clients who are being discharged, they can actually enroll in services so they can leave residential, not just with a prescription for psychotropic medication, but they can actually leave with 3 months worth of medication. Plus they get to make appointments because many of them have medical issues. So on that bus, they will sign up for health insurance. They can have medical appointments. So once they leave residential, they have doctor's appointments set, they leave with medication. We get housing with them because as the leader said from BBUC, there's certain FAR certified recovery houses that are funded through them. So we try to link them with those houses so they can continue on that service. Yeah.
You said something there on compassion that's really important, what you did with the lady who was jaundiced. If we looked at her medical records, what would they label her? Who would the last doctor saw her, somewhere in his notes, what were you and her say? They'd say they're non-compliant. All right, and you took that a step further. They're non-compliant because they had these barriers that you overcame, and that's the kind of stuff that I'm talking about right there. So thank you, and I'm glad you came up, by the way. Natalie, so you're up. What are some positives about working with people in the private sector? For me, the positive has been a lot of times the private sector is more nimble. I mean, I see that, but I want to hear your thoughts on that, and if they're more than that.
Thank you very much, Dr. Lloyd. So there's a couple words that we've been hearing. Coordination and care, collaboration, silos, and data. Okay, these are key words. These words are extremely important. So let me go back a few years, about a decade and a half ago. The Florida legislature created, I realized that the Florida system of serving individuals in need of behavioral health services was very antiquated. And so what they did at that time, they created a safety net system. The managing entities called the Florida Behavioral Health Managing Entities, and there's 7 of them around the state. They cover the entire state of Florida. One of them is Broward Behavioral Health Coalition. And with the managing entities, their intent and their goal are to serve those individuals that are uninsured or underinsured that need behavioral health services. Okay, but this role has transcended. It's transcended because now our population has advanced and increased. Yes. So what has happened? So not only now it's underserved because of the opiate settlement, now we're serving beyond that. All these dollars are coming in. We are now managing north of $1 billion, those 7 managing entities. And every day in the state of Florida, how many people come in? Well, I'm hearing about 1,000 people a day. That was last year's. I don't even know what it is this year. So managing entities are here to serve those populations. But what does that mean, sir? Okay. It means that those dollars that come through federal and the state go down to the Department of Children and Families. And DCF, called DCF, you're very familiar with. And DCF then allocates those dollars to the 7 managing entities. Now, what do? What do you do at Broward? Based off a needs assessment in the community. Remember what I'm saying here? In the community, the needs assessment, the data, what is needed in this community. Then they contract out with their appropriate providers. Now, back a decade and a half ago, that was a few providers. Now, how many do you have? 50 providers right here in Broward County. That would not have happened. Okay, Dr. Caulfield, you have about 90 providers. Right in your area in the state of Florida, it's over 300 providers. Now, why is that important? Because not one provider can do everything. So, for example, in your community, you have great prevention work. In fact, Broward's really known for their prevention work because of you guys, what you're doing here. I knew about it, what Broward's doing because I heard about it. Because Sylvia and Broward, they contract out with you guys. But the thing is that what is it? Are you guys the same as Marion County, which is Central Florida? Are you guys same as Marion County? Do you have the same? No. So why did you want the state to dictate what you guys are doing? Why did you want Washington, D.C. to dictate? Why would you want some national organization saying, we've got this great model. We want it to come down here because we got a great outcomes in the state of Idaho. No, this is what we do here. You guys know what is needed in this community. That's right. Now, that's called a network, and that is called that coordination of care to help that individual for the services in your community that is right for them. So that is the role of the managing entity, make sure that we have a network of providers in the community. Now, at state level, what do? We work with at state levels, sheriffs, you talk about the counties, all of those types of organizations. But I was thinking about this today as you guys were speaking. There's usually like this road. And in that road, look at it as I-95. On I-95, you're going a nice 70 miles an hour, right? Right? Okay. So you're going on that road here, you're going down this road, and you start seeing and you're feeling comfortable. You're feeling really comfortable. Okay, you've got some people passing you at 100. All right, but you're feeling comfortable. We feel comfortable in our behavioral health world, our network. Okay, it's real easy for us, especially we had a program that the governor has been pushing, and we DCF took control of that particular program, and with that, they contracted with the managing entities to implement that program. Well, with that, we were very, very confident with the behavioral health providers because we had that network, and you guys know what you're doing. However, who else are we talking about? We're talking about people outside of behavioral health. We're talking about law enforcement. Now, they're in a little different world because they're kind of in the middle of it too. But we're also talking about EMTs. We're talking about the counties now that really didn't have a world in the behavioral health. Now we're talking about school systems. Oh my Lord. So school systems, this is a different interstate now. It's like in India. Have anybody been to India? Have you been on one side of the road? Have you been, they travel on the wrong side of the road. They drive on the wrong side, like Great Britain, right? But if you come up on a wreck, you're going to sit there for hours. Right now, you're not. You know what they do? They go on the other side of the road with incoming traffic. Okay? So I'm sitting here thinking, oh my Lord, I'm not coming back to Florida. Well, my point is this. You've got people coming at you at 100 miles an hour, but then you get over, right? My point is that you've got to get in a different lane, and you're going to have people coming at you. But law enforcement's a different lane. But the great thing is you're breaking down those silos. And if we break down those silos, we start working together. Look at Broward County, and look what you guys are doing down here with your law enforcement. I wish the rest of the counties can do that. Look at your school district now works with Broward Behavioral Health. Why? Because because they know that there's a network of providers that that school system can depend on making sure that that student may be getting the counseling in schools. But if they need counseling afterwards, if they need counseling on the weekend or the summer, then they can make sure to have those services because of that collaboration of that network. So there are some wonderful examples, and I really appreciate the fact that we're patting each other on the back, because you know what? You deserve it. You deserve that. However, of course, there's a lot more to be done. And if we can keep breaking down those silos all across and take and widen up that I-95, what a system are we going to have? And we're going to do it.
Thank you. We're actually doing that started by multi call, so we can all come up here. All that leads into to my friend Mark York, and what we talked about all day today. You know, Mark, what's the importance of an opiate abatement council for Broward County?
Well, first, it's, you have to agree. There are dynamic principles to play politics, treatment services. Some people don't even want the word harm reduction used out there. Some people don't want addiction. That's nonsense. People are dying. It's a responsibility of people in this room to create a consensus to fix it. How you fix it is not difficult. This isn't intellectual property where you have to, you know, this nonprofit is hiding some IP. Everybody's in the business of treating others, whether it's mental health, addiction treatment per se, or anything else. There's youth, others. You have an opportunity right now for a public-private initiative. There's a guy sitting right down there that is HCA Healthcare. That's a $60 billion with a B revenue company. That opportunity doesn't walk down the street any day, anywhere in the United States. There are people and principals from leading entities in Broward County that are here, that if everybody gets rid of the blinders and starts looking at the opportunity that's in front of them, well, hey, maybe if we just agree that we're going to start talking about common interests and how to kind of get across that hurdle, which is we don't talk to them because of what happened 5 years ago. Get rid of all that nonsense because people are dying.
Right.
Let's say 600 people died in Broward County last year. That's about 1.5, a little more than 1.5 a day. Everyone drive by the accident, they see first responders, and they feel bad, but get down the road. They're like, oh, okay, that's, you know, well and done. If 1.5 people started popping up on the beach in Fort Lauderdale, after about 3 days of that, everybody would be like, oh my God, we have to stop that. We are disenfranchised about the actual cause of why everybody's here, because people are dying and there's addiction, loss of jobs, family, DCFS, NAS babies, which I'm very, very familiar with. That is, you know, an ongoing healthcare. The people that started in the opioid crisis 20 years ago are now adults in the workplace. That, you know, the mom doesn't go up to the school 5 years old and say, you know, he's an NAS baby. You know, he's like, oh, he's just high strung or ADHD, and they give him pills, and from that point on, everything is done. So, all right, I'm getting a hook. So everybody, I think coming from this, we should all agree to engage as a group, as well as siloed discussions to create a consensus on how to solve the problem. And one of the best guys that's involved in it, right there, Stephen Lloyd.
Yeah. Thanks, Mark.
Thank you, everyone.
Yeah, thank you, guys. Like I close all of my thoughts that I do, because it's so important. We started off today, basically, I wanted you to see our why the heck are we here?
Right.
So my daughter got married about 8 years ago. I gave her away. It was on my right arm. I went in the program that night, in parentheses. I'm still May 11th, 1967 dash. All right. My son got married a few years ago. I was the best man in his wedding. He played college baseball. He's got 100 buddies. He asked his dad to be his best man. 2 most important days of my life, I was there. Karen had married the pool boy. All right. That's what people who are using want. Nobody wants to wake up in the morning, guys, and stick a needle in their arm. I promise you that's the case. And if we keep our focus on that, then we're going to be fine, right? I'd see us getting sidetracked when we start getting off into our own stuff, me included. My own ego, my own fight, my own war, whatever it is. The hardest thing for me standing up here today is to keep my ego out of it. keep focused on who we're trying to help. And I will tell you this, that was my two favorite stories that I used to close my talks with. But on September 15th of last year, I became a granddad. And so I'm back in Tennessee. I've got TT waiting on me when I get home tomorrow night. And hopefully I'll be there in time for her bath. So, guys, a normal life is underrated. It's underrated. And that's a quote from my college roommate, and he's exactly right. We're trying to help people find that path to recovery that gives them those payoffs, those rewards. Thanks to our panel. And we will go and
so that brings us very close to the conclusion of our program today. And I'm proud to say that we are on time. We were scheduled to end at 3:10, and I think it's 3:12. So that's pretty amazing, all things considered. So we just want you just to stay put for just another 10 minutes or so, because we have a couple of acknowledgements to make, and then we'll cut you all loose and wish you a great day as soon as they're done with the photographs. The one thing I did want to tell you was that we want to know what we could do better. I think this is probably a good experiment today. And it was, there's lots of room for improvement, and we're going to send you out a survey in the next couple of days. So we hope you take a few minutes to fill that out and tell us, most importantly, what could we do better? Deal? You guys respond to that? Let us know. Okay. Well, thank you very much. Veronica, did you want to say something? No. Okay, so Kathleen Cannon is going to come back up here, and we're going to do some acknowledgements.
All right, gang, I know everybody, oh my gosh, thank you so much for hanging in and being involved and doing the work. Something Gerard mentioned, I think is really important. And actually Dr. Lloyd mentioned it too, the humanity, right, of folks that we really try to serve and what we do, that we cannot let go of and we cannot forget. So I have two awards to really hand out, folks. Dr. Patrick Chapman, please come up here from HCA, really funded this in such a big way. So we have something for you, but you're gonna stay here for 1 second and you're gonna always acknowledge. Where is Stephen Lloyd? Here, I know, you thought you were off the hook already. You're not. We are gonna get you out of here on time, because you do have a grandchild that you're getting home to, but we wanted to present this to you because you are kick-ass phenomenal, and we really could not have done this without you. Your message is so vital. So another round of applause for these two gentlemen. Thank you so much.
So my couple of words, it'll be additional to it is thank you, Kathleen. Thank you, Kennedy Hurd. Thank you, Gary. Thank you all for being here and spending your time with us today. It was wonderful to be here, learn from all of you. Doc, you did a great job. If you ever wanted to give up being a doc, I think you got a great job and the price is right. Or you were fantastic, kept us going, kept us laughing, and helped all of us guide this. So I want to thank everybody for what you do every day. We're all in this together to get it done, take care of our people, our neighbors, our friends, our family. And I just ask all of you to continue doing what you're doing and lift them up. So thank you all.
Appreciate you both so much. I do want to hand two of these out and then we'll kind of close up with a call to action. So Kathy and Gary, if you guys would really come up here. Did I do something? Okay. Gary, Kathy, okay. We have flowers for you, dear sir, because you were amazing. And Miss Kathy, talk about the power of two people, the power of volunteers, putting this together, getting everybody in this room, doing all that you do. I cannot thank you enough for being in this community, for pulling this together, being the brains. And then we'll do the call to action together, the three of us, because today is just the beginning, right? Because this is about pulling us together. This is about identifying our amazing partners, the county, the sheriff, the fire chief was here, and the assistant chief was here. There's so many deputies here. There's obviously nonprofits here. There's for-profits here. There's folks that have been affected by this. There are public policy people here, governmental legislators. So we have been doing the commission, which is about pulling people together. But there is people and all of you are doing amazing work, but sometimes, and what Natalie had said, sometimes we're all doing great work, but we're not always lined up, right? We've got some going this way, this way, this way. We need one plan that we really all abide by and that we're all driving and that we're all rowing in the same direction to save lives. So if we can garner all the amazing work that you're doing, and there's folks that aren't sitting in this room that are doing great work, and there's folks that are not sitting in this room who are critics of the work that we're doing. So we have to try to rope them in and make them understand how important that this work is. So you said you were going to send out our survey, or we're sending out a survey, someone's sending out a survey. So we do need your voices about, this is the first annual, the first national. So we want to do this again, but we want to deliver it for exactly what you need. And then we're going to ask you who's not in the room that needs to come back next year. How do we deploy this one movement all together through Broward County and beyond and make sure that we're saving lives? So I thank you guys for hanging in here all day. I know it was a long day. There was so many amazing speakers. And Kathy and Gary, I want to thank you guys for championing and talk about the power of volunteerism, because they have jobs and they did this. So Franz and Angela, I want to thank you guys from United Way, the staff. You worked so hard. Franz, we're running down one and so the hard work, I appreciate you all so very much. Thank you. We'll see you around for all this work that we're going to do, but of course we'll see you again next year. We need committee members, so we do. So we've got the different committee members, CRT, etc. But we are looking for volunteers to join committees. The committees don't just sit around and chit chat and talk. There is action that takes place. We talked about no outputs, right? You could tell me how many people you served, but what happened to those folks that you served? It's outcomes that we're garnering and measuring. So we need folks to sign up. There is going to be a sign-up sheet at the door as you go out. So maybe we should just stand there and block everybody as you walk out and sign you up. No, but please, if you have an interest of joining a committee, please put your name at the front. We have something at the Behavioral Health Conference. You talked about that. So it's going to be the 10th annual. It's in May. It's not at the Signature Grant because the Signature Grant is closed. So don't automatically go there. It's at the Convention Center, 2 days. We're Celator. We started a faith-based portion of the Behavioral Health Conference for faith leaders, so that they really come to the table and talking to their members of the Christians, etc. So please join the Behavioral Health Conference. We make it affordable for everybody. We do need sponsors as well. So if you're willing to sponsor, I know the county is a sponsor. Thank you guys for sponsoring the Behavioral Health Conference. Patrick, am I putting you on the spot? You're probably sponsoring, right? All right, we'll talk to the money guy. So I won't put anyone else on the spot, but it's a really important piece. We'd love to see you all there. So please join, and thank you guys very much, everybody. Thank you. Have a great afternoon. A great week.
Real quick, everyone, thank you once again. And one quick happy birthday to our beautiful CEO. Her 21st. I'm not saying happy birthday. But she is known for taking selfies. Perfect. Thank you, everyone. Thank you. Sign up. Please, thank you.